It's more people have cameras. That's great. All right. It's a brave new world. I think we are on YouTube now. Oh, Colleen says I have to wait another minute. There we go. Okay, great. So welcome to this interim meeting of the Health Coverage Insurance and Financial Services Committee. Somebody's got a mic open.
Sorry.
Who it is. Christy, can you go ahead and leave the computer audio? Great. Okay. Thanks. Still open. Okay, great. Thanks. Okay. So we are experimenting with this hybrid format, and it's going to be a little bit bumpy. I think our committee has been really great on the remote format, and we were hoping to do basically just an in-person meeting this time around. And I was really looking forward to being in Augusta. Unfortunately, I have COVID, so I am not in Augusta. There we are. So we are going to practice this hybrid format. It's a little bit tricky to chair remotely when there are folks in the room. So just bear with me and we will make it work. I am confident. I have observed the way the Judiciary Committee held hybrid meetings, and it worked very smoothly, actually, surprisingly so. So with that, I will just welcome everyone to this interim meeting and thank folks for joining us outside of the usual committee schedule. The topic that brings us together is a briefing on the issues that have arisen between Maine Health and Anthem that have been well covered in the media related to payment disputes, contractual disputes, and network issues going forward. There are some oversight duties, I think, of this committee as it relates to our oversight of the Bureau of Insurance and the State Employee Health Plan that are implicated by this Maine Health Anthem issue. And so I felt it was, Representative Tepler and I both felt it was extremely important for us to hold an interim meeting immediately to get briefing on this. I expect it's possible we could have additional meetings throughout the interim as the situation progresses, if necessary, in our oversight capacity. And there could be legislation introduced next year related to this, but the immediate purpose of the meeting today is not a legislative one in terms of creating new law, but an oversight responsibility as it relates to that Bureau of Insurance and State Employee Health Plan responsibility. So with that, I will go around and have the committee introduce themselves, and this is where we get to practice using the correct microphone. So I will start with Representative Quint.
Hello, my name is Tracy Quint. I represent House District 144, which is 17 communities in the Holton area.
Great. And Representative Matheson.
Good morning. My name is Christy Matheson. I represent District 1, Kittery.
Representative Arford.
Good morning, Madam Chair. I am Representative Poppy Arford, and I represent District 49, the western part of Brunswick.
Great. And just a tip for folks that if you lean forward and speak, then we just see your name tag in our screen. So you might want to turn your microphone on and then sit back for the camera as well. Representative Evans.
Good morning, Madam Chair. I am Representative Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover Foxcroft, Medford, Milo, Ornerville Township, and Lakeview Plantation. Thank you.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Representative Mark Blyer, represent District 22, which is part of Buxton, all of Leamington, and part of Standerson, Limerick. Thank you.
Representative Melorano.
Thank you, Madam Chair. My name is Gina Melorano. I represent House District 62, which is part of Auburn.
Oh, and I just realized I skipped Representative Connor. Representative Connor, go ahead.
Thank you, Madam Chair. My name is John Connor and I represent part of Lewiston.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and Livermore.
Senator Brenner.
Thank you, Madam Chair. Good morning. My name is Stacy Brenner. I represent Senate District 30, which includes all of Gorham, most of Scarborough, and part of Buxton.
Great. Representative Tepler.
Good morning. My name is Denise Tepler. I represent House District number 54, which is all of the lovely town of Topsom. And I also serve as House co-chair of the committee.
Great. And Colleen McCarthy-Reed is with us as always, our analyst from OPLA. I think she doesn't have a microphone, so we'll just wave at her in silence, and unless we need her, we'll send her over to the horseshoe at that point. Okay, so the order of operations this morning is that we will hear first from Maine Health, then from Anthem, then we will invite the folks from the Bureau of Insurance to join us, and then the State Employee Health Plan, and then we'll have a public comment period. We will be limiting the public comments to 3 minutes per speaker, and I'll time that on my phone and put the timer up in my Zoom box, which hopefully you guys will be able to see as the time elapses. So we'll get to that part later on. At this point, I'm going to need to be made a, what's it called? A master of the meeting, a chair, no, what a host, that's it. Boy, it's been a little while since I've been on Zoom. So I need host privileges so I can move people over. Perfect, great, thank you. So I'm gonna move the folks from Maine Health, Andy Mueller and Al Swallow, over to our panel. I can find them. All right, I see Andy Mueller. I don't see Al Swallow, so he may be in the same Zoom box. Good morning, Mr. Mueller. I don't see Al Swallow on our screen. Is he there somewhere and I'm missing him?
I know he's intending to join, but I don't see him on the screen.
Okay.
I think we have somebody running to his office. I'm happy to go ahead and start if you'd like, whatever you think is appropriate.
Okay, well, why don't we go ahead and get started, and we can start by giving us an introduction of your role. He may be Katie Harris. There's two of her. Okay. I'm going to move both Katie Harris's in, and then we'll see what happens there, and we can move her back if she wants to be moved back. All right, so hold on just a moment and we'll see how that goes as we pull a couple more folks through the wormhole here this morning. Oh, neither of them is coming. Oh, there we go. Okay. My apologies for coughing into the microphone, folks. I'm going to get through this morning and then I'm going to take a sick day for the rest of the day. Okay. All right, perfect. There we go. And I assume that is Al Swallow. I'm going to rename you.
Clearly, it's the
And
prettier version of Al Swallow.
there we go. Okay. So we are all set now. So please proceed with your briefing of the committee.
Sure. Senator Sanborn and Representative Tepler and all of the distinguished members of the Health Coverage Insurance Financial Services Joint Committee. Thank you for your time this morning. And I really want to start with a heartfelt, I'm so sorry. I'm so sorry that we're at this point right now. And I'm a family physician who is presently serving as the Chief Executive Officer of Maine Health. I'm joined by Al Swallow, who is our Chief Financial Officer and a gentleman who I hold in high regard, a native Mainer. And as a family physician, I've spent my life trying to help people avoid suffering, avoid harming them. And I recognize through this decision that we're inducing a little bit of harm, which I think gives you a sense of the magnitude of this decision for us. This was not something made lightly. And I can promise you, we have no interest in trying to prove a point or make a few nickels or dimes or anything of the such, but this is something that is much greater than that. And frankly, we fear is existential to us as a healthcare system and potentially longer term to how healthcare is delivered in the state of Maine. That's what got us involved in this. So I will begin by stating that at Maine Health, I am bound and determined we are going to live our vision of working together so our communities are the healthiest in America. That is something that really brought me to Maine. I'm a lifelong Southeasterner and had lots of other opportunities, but what got me excited about Maine Health was the chance to do something different here. I agree, healthcare is broken. I saw it as a physician. I've experienced it as a patient. I've watched many of my family members have to endure some of the challenges in healthcare. And we've got amazing, heroic frontline nurses, physicians, respiratory therapists, physical therapists, others who every day go above and beyond for our patients and each other. And all of you have seen that, experienced it, witnessed it. But for some reason, when we add it all together, the sum of the whole of our healthcare system is not as good as the sum of the parts. Our vision is working together so our communities are the healthiest in America. Our business model is admit as many people to the hospital, charge for services, and submit for reimbursement. They don't align. And what brought me to Maine Health was a unique set of circumstances that I think gives us a chance to realign that business model to better align with our vision of working together so our communities are the healthiest in America. To be sure, we talk a lot about that vision. I want to make the organization completely clear about where we're headed and what we're going to do. And the journey ahead is not easy. But as we talk about that vision statement, there are two words that are really important. One of those words is community. And if I think about my own rigid way of looking at the world, it's easy to think about community in terms of the geographies we serve, but it's much more than that. It's really around how we define belonging in Maine and Carroll County, New Hampshire. It's whether you live in a rural community or an urban community, whether your skin is white or brown or black. It's whether you're an immigrant to our nation or whether you grew up here. It's however you identify yourself. And we have an obligation to think about how we care for everyone in the communities we serve. We also talk a lot about that word together because we recognize that ambition of working together so our communities are the healthiest in America is so aspirational. We can't do that alone at Maine Health. We're going to have to partner with lots of different people and organizations to help us do that, whether it's the state government of Maine, whether it's our payers, whether it's the independent physicians, whether it's the other healthcare delivery systems in the state. We have to be good at partnering with others. That's core to who we are. At the same time, to begin that journey of transforming our healthcare system, we got to survive the next couple of years, and that's not an easy task. We are just recoiling from the impact of COVID. We have a completely exhausted workforce that have been beyond heroic in really stepping up at the front lines and providing amazing care to the communities we serve. We have moved mountains to ensure that we're immunizing, that we're testing, that we're doing all of the things that we need to do to help make sure we're caring for the community. And we've provided inpatient hospital care for more than half of the patients in the state who've required it for COVID during the pandemic. And that's come at a huge toll to our care team, and it's come at a huge toll to the financial health of our healthcare system. And through this journey, one of the things that I think is so important for all of you to understand is that we have learned that if our goal is to create pure efficiency by driving care to Portland, Maine to Maine Medical Center, we're not going to be successful. We have to continue to make meaningful investments to ensure we can deliver high quality advanced care in all of our hospitals and communities, including our rural hospitals and communities. And as we're trying to figure out how to do this, we've ended up in a significant situation where Anthem is changing the way they're paying us without the ability to influence those conversations at a hugely problematic time for us. In fact, we feel like we're down and wounded, and we're getting kicked pretty hard at the worst possible time, not just financially. Frankly, all of us have more important things to do than be in a contract dispute. I need to be with our frontline care team members. Our leadership team's energy and focus during the height of the pandemic has been distracted by this issue. So what are the troubles that we have? Well, Anthem owes us over $70 million in payments, and we're not the only providers in the state that are in this situation. And frankly, we've been incredibly patient around that. But what brought this to our attention is right after I arrived on the scene, just about 6 months after a brand new contract with Anthem, they just began withholding about $13 million in annual payments to Maine Medical Center, over $1 million a month. This is material to us. This is about 0.5% of margin for us as an organization. And while the rate reduction doesn't sound big, about 4.25% to Maine Medical Center, it's off our bottom line. It's huge to us. And when you consider the fact that about half of our inpatient care is delivered at Maine Medical Center, it's more than a 2% impact to our bottom line from commercial insurance across the entirety of Maine Health. It's really material to us. And part of the challenge that we have is that we have an agreement with Anthem that gives them the ability to unilaterally change policy. And I think when that contract was signed before I arrived at Maine Health, it was signed without a belief that that would change payment policy. That in other words, Anthem could change the rates they pay us without any sort of appeal or any sort of discussion. Yet that's exactly what's happened. I'll give you an example of one of those policy changes. This actually happened this past January while we're in mediation with Anthem around these things, because they've implemented a policy that we can't bill for more than one procedure on some patients performed in a day. And so on my desk, I've got an example of a denial that has the Anthem policy attached to it, explaining that we can't charge for more than one procedure on a day for a woman who underwent a hysterectomy for cancer. And the surgeon decided to do a lymph node biopsy to ensure the cancer hadn't spread. And the biopsy of a lymph node was denied for accordance to their policy. And we don't have any recourse or repeal options for that policy. We have no way of engaging Anthem in those discussions based on the terms of the contract. And in our discussions with Anthem, they've been pretty clear. It's in the contract. Now, why on earth would we agree to a contract like that in the first place? And that's a pretty fair question. And while I wasn't here to speak to that, and having conversations with the leadership team it was pretty clear Anthem would not accept an agreement with Maine Medical Center that didn't include that provision. And so that put the leadership at Maine Health in the really dubious position of having to decide about 18 months ago, do we do this? Do we go out of network with Anthem? And because of the grave consequences of doing that, they felt like they had no choice other than to sign the contract, knowing that eventually a remedy existed if Anthem was taking advantage of that contract clause, which we believe they are. And that remedy was to give notice and terminate the contract. And that's what we've done. And we're trying to do this in a respectful way to give everyone time, including the Bureau of Insurance, Anthem, and our team to prepare in the hopefully unlikely event that we can't get to some sort of term on this. So instead of giving the 90 days, which is allowed in our contract, we've given far more time than that to try to be fair to everyone. And we restricted this to simply Maine Medical Center. I think it's important to understand that part of Anthem's perspective of this, and I think it's a reasonable one, is to hold us accountable for the cost of care in our communities. We recognize the expense of healthcare. When the agencies that effectively assign credit ratings to individuals are no longer considering healthcare debt because it's so ubiquitous, it's a problem. We've got to figure out how we can engage responsibly in solving it. If you've seen anything that I've had in the media prior to all of this sort of exploding, you will have noticed a quote that I use all the time because it's so profound and true, that in the United States today, the two most important vital signs in predicting your mortality are not your blood pressure, your pulse, your respiratory rate, your weight, your hemoglobin A1C, your cholesterol. It's your credit score and your zip code in that order. The economy of a community and a region is tied directly to the healthcare outcomes. There is no question about it. If we're going to live our vision of working together so our communities are the healthiest in America, then we have to support the local economy. If our employers in our community are struggling, it's bad business for us. And more importantly, it means we're not going to be able to achieve that vision. We have every reason to align around the notion that we have to be thinking about how we can be responsible in helping our employers help lower their own healthcare costs. That's something that's really imperative to us over time, and something that we'll talk about in just a minute. So we're aligned with the notion that we need to be cost effective as an organization. And we believe that it's important that we partner with all of our community partners to change the historic healthcare model of extracting financial value from the economy to rather creating it on the flip side through the care delivery that we provide. For those of you who aren't in healthcare every day thinking about it, I think it is really important that you understand the landscape beyond our region because it is changing violently. And we've escaped it and been fortunate from some of that change in the short term, but eventually that change is going to come spilling upon our shores. And when you look at what is happening out there, I got to tell you, I laughed just a little bit at some of the media reports around these two behemoths competing with each other. Because at the end of the day, we are a big organization for sure, and we'll generate more than $3 billion in net revenue this year. But Anthem's going to generate more than $140 billion of revenue this year. This is not two equally sized behemoths fighting each other. If this was ever a David and Goliath battle, this is it. And I actually empathize with the challenges that Anthem faces because they're in a tough spot on a number of fronts. They've got to preserve their historic 5 to 6% margins. They've got to hit the growth targets that Wall Street sets expectations for, which for about $140 billion of revenue a year is about $10 billion in incremental growth, about more than 3 times the size of Maine Health. They're competing on a national scene to try to grow revenue in a market that has been largely static for the last 10 years. There's really not been large market share shifts at the national level for commercial insurance among all the large commercial insurance players, which makes their challenge difficult. And it makes it even more difficult when they've got competitors who are over $300 billion in revenue on an annual basis. We've been immune from all of that influence of really big business on healthcare, but it is impacting other communities. And the way that that's happening is the large commercial insurance companies recognize that there is money to be made on commercial insurance and Medicare Advantage. And they're going after all of those valuable services and healthcare systems. And I had a conversation with a healthcare CEO who does business in the state of California and leads an organization that's well over $50 billion in revenue, who is fearful for the future existence of their healthcare system as the very large payers are starting to go after what creates value in those healthcare systems and extract it out for the commercial and Medicare Advantage patients, leaving those with Medicaid who are uninsured and underinsured behind. And so if we're not careful, we run the risk of something similar happening here. So while I'd like to tell you that the experience we're having with Anthem is, a one-off type of scenario, I can tell you I've never experienced anything like it before in my entire career. I can't tell you that I haven't seen it before, though, because I have. When I was a healthcare system CEO in the state of Virginia, where Anthem is present, I witnessed the aftermath of a really difficult, similar scenario with the Augusta healthcare system in Virginia and the tremendous pain that it inflicted on that community. I witnessed some of my colleagues pulling out their hair, trying to figure out how to deal with some of the tactics that Anthem uses when they negotiate with healthcare systems. And if you think we feel some of that as a $3 billion healthcare system, imagine what our independent physicians and practices feel, what the smaller health systems feel, knowing that the scrutiny and the risk to them is if they ultimately terminate their agreements or don't come to agreement with them. Anthem has all of us in a difficult position in terms of their ability to leverage that fear in all of us, because none of them want to create harm for any patients in our communities. When you think about the situation at Maine Health, it's also difficult. It's not any easier. In fact, we just try to get to a 3% margin, and we do that through voluntary compliance through the Dirigo Act. It's our intent to try to maintain a modest margin. We don't spend things on excess. We're really committed to reinvesting in our care team and investing in those services that are critical to the state of Maine. And through COVID, with the incredible amount of CARES money that we've received from both the state and federal governments, which we're unbelievably grateful for, it has put us in a situation that on average for the last 2 years, we've had a 2.5% margin. A 3% margin, we believe, is the minimum that we're going to need just to make the needed investments in our care team and our infrastructure. That doesn't really include growth, transformation, innovation, anything like that. And we've got to reset our sights on how we do all of that within a 3% margin. We understand the pressure that healthcare can put on the employers in our community. Now, this year, we're not going to get anywhere near a 3% margin. It's going to be closer to a 1% margin. And without identifying over $100 million in savings opportunities on the cost side, then we're going to have a negative margin we project for 2023. And in the middle of all of this, we're having our payments withheld from Anthem and previous payments that were owed, not paid to us during a really critical time for our healthcare system. So we recognize that we're going to need help. When we think about what we've done, we've got to balance the need to provide critical services to our community that we're the only provider for. Things like level 1 trauma, pediatric advanced inpatient care, ECMO, stroke care at Maine Medical Center. We have to preserve those services for our community if we're going to continue to deliver what the community expects and needs from us. And we have to balance that against not only a workforce that expects and in some cases demands to be paid more. We've invested $150 million in employee compensation over the last 18 months, bringing even our minimum wage up to a living wage for our region, and wanting to do the things to keep them competitive and paid fairly, and try to do the things that we can do to help them. We've even spent an additional $2 million on virtual behavioral health for every single one of our care team members and families, recognizing the challenges that they're under in the present scenario. And we have to balance that against the recognition that in most of the communities we serve, we're either the number 1 or the number 2 largest employer. We have a huge economic responsibility to our communities, and restricting our payments, particularly in the way that they're being done, puts all of that at risk for us as a healthcare organization, and really starts creating a scenario where healthcare decision-making about resource allocation is not being made at Maine Health, and it's not being made in Augusta. It's being made in Indianapolis, which is a problem. Now, we recognize that 5% margin
Mr.
swing.
Mueller,
Yeah,
we've
yes,
been
ma'am.
going for about 15 minutes. I'm wondering if you can kind of wrap up your presentation for us.
I will. Yep. We're going to do the hard, heavy lifting to try to find a good percentage of that 5% on our own, which means hard conversations, difficult things. Yes, $132 for saline. I hate cost shifting, and we can do things to change it, but not at the rate that we're going. Yes, the RAND study showed we were the fourth most expensive state in the nation, but the study was designed to show healthcare effectiveness, which we were the number 14th in the nation in terms of access, quality, and healthcare outcomes. Kaiser Family Foundation ranked us 24th in the nation in expense. We are committed to making changes, committing to partner with new insurance entrants like Taro Health that's coming to our marketplace, including taking deeper discounts to allow that. And we're going to do everything we can to keep the residents of Maine able to get care at Maine Medical Center. Everyone will have access to care. Those who have emergent care will be required by law to receive their care there. And we're going to do everything we realistically can to try to minimize the financial impact. Heaven forbid we can't get to an agreement. And yes, we are still, despite what you may have read in the press, engaged with Anthem at the mediation table, trying to resolve this. And we certainly hope that we do. To achieve our vision, we're going to have to do some hard things. And unfortunately, this is one of them. Thank you for your time.
Thank you, Mr. Mueller. All right, questions from the committee. And actually, before we turn to questions, I'm just going to let everybody in the Zoom know that the chat is not to be used for substantive comments or questions. It's not part of the record of the hearing, so we will be ignoring that. We use the chat only to sort of sort out things like who is Al Swallow logged in as, and other sorts of technical issues. So please be advised of that. All right, so turning to committee questions, Representative Evans, go ahead.
Thank you, Madam Chair. I have a couple of questions. Dr. Mueller, thank you for being here. The two questions, maybe three that I have is, one, what is the duration of the contract that you currently have? When was it signed and what's the expiration date?
Al, I'll let you take that if you want.
It was signed in January of 21 and carries through December of 24.
21 to 24. Now, the other thing is the rationale. What's the rationale that you have received from Anthem regarding being able to charge for only a single procedure per day? Were you given a rationale on that?
I'll let you start with that.
No rationale other than it's a policy that they elected to implement. Notably, there are some states that are excluded, and there's language that suggests they could be excluded from some specific provider contracts, but they have not afforded us the opportunity to do that.
Okay. And the final thing that I wanted to ask, are you doing bundling in your charges for the hospital?
Depending on how you describe bundling, certainly there are supply items that may be used in a procedure or in the care of a patient that would be included in other charges. That's normal course of business. Part of the dispute arose with Anthem in trying to change some of that to comply with their routine audits when we may have charged individually for those items previously, and they were denying payment for those. And so we then tried to package them or bundle them into other items as they were requesting.
Okay, thank you. Thank you, Madam Chair.
Okay, Representative Tepler.
Thank you, Madam Chair. I have several questions as well, if that is all right. I guess most of what I'd like to do is sort through some of my confusion about the financial information that Mr. Mueller presented to us. So what I heard him say is $3 billion in net revenue. And I guess unclear on what net revenue in this case is. And does that constitute the 1% margin that Mr. Mueller referred to, or is that a 3% margin? And I need some clarity on the financial information that was presented.
Sure. So as a healthcare organization, we submit charges for the services that we've provided. Based on the contractual arrangements we have for our payers, we get paid at a specified rate. So net revenue is what we receive after after dollars come back to the healthcare system for the services provided. And it's a little over $3 billion, roughly. Now, our target is to generate a margin of around 3%, which would be roughly $90 million. And that's our hope. And of course, since we're a not-for-profit institution, we don't pay shareholders. We have to reinvest those dollars in our team and the infrastructure required to deliver healthcare and meet our obligations to the community. This year, we're going to end up closer to a 1% margin because of the challenges that COVID has inflicted upon us, mostly around increasing expenses, which have been dramatically increased this past year, as well as reducing non-emergent surgical procedures to care for the sickest patients in the state with COVID back in the winter. And those non-emergent surgical procedures typically generate a higher return, generate a higher margin for us. And so that's put our healthcare system in a real difficult situation financially at the moment.
So, Mr. Mueller, if so, 1% is approximately $30 million.
That's correct.
And that's $30 million above costs to the entire system.
That's correct.
Okay, that's part of what I wanted to understand. And there was also mention of a 0.5% margin in terms of the balance sheet. And I wanted to hear more about that. And one more quick thing that may go with that. The $70 million that's owed, is it owed to the system or to Maine Medical Center?
So I'll start with that. And then if it's okay, I'll turn to my colleague, Mr. Swallow, to finish the second part of the question. So when you think about the withhold that is presently occurring, it represents a little more than $1 million a month to Maine Medical Center, which represents $13 million in total over the course of the year. If $30 million is 1% of margin, $13 million is close to 0.5% of margin to us, just to give you some perspective on what that means to us as a system. And then I'll let Al answer the question about the $70 million.
Yeah, the $70 million represents a backlog of claims over 120 days old that have not been paid to the system as a whole, much of it because of these policy issues we've described. And in addition to that, we're on a periodic interim payment basis where we're paid weekly for cash flow purposes from Anthem. Those amounts are to be settled periodically after the completion of a year. We're 2 years behind on those settlements, and Anthem owes us $42 million on those settlements. So that's the combination that gets you to the 70 million, both of those system-wide.
And do they agree to those figures, Mr. Swallow, the 42 million? Do they agree that that's what they owe you in terms of resettling?
The settlement for those periodic payments is in process, and I believe that those will be agreed to. The claims that are over 120 days old are disputed because of the perspectives that we have on those policy changes.
Okay, thank you. And thank you, Madam Chair. I'm all set.
Okay, you're all set. Okay. Representative Bleier, go ahead.
Thank you, Madam Chair. Thank you, Mr. Mueller, for being here. I heard you speak a lot about efficiencies and investing in Maine Health for efficiencies. And to me, efficiencies mean reducing cost. And from what I gathered from your conversation, there's no reduction of cost there, but an expansion of cost. Could you explain that a little bit more?
I don't think that anything anymore can be thought of as an either or. I think it has to be a both and. So we have opportunities on our end to do things to improve our financial performance and in some cases reduce cost. One of the benefits of us being as a system is we can realize value, both financial and clinical quality value, by doing things like appropriately reducing clinical variation. That's a big initiative that our system has not really fully undertaken yet, and we intend to do that. We think we can drive significant bottom line savings from doing that, but we also think we can save lives by doing that. And so that's something that our clinical care team is going to be working on diligently over the next couple of years for those really important conditions where we can do that. So I think we've got to think about how we can reduce some of those costs within our system. And there are lots of other things that I think we can do. Those are hard conversations. That involves changing practice patterns, disrupting the way physicians have done things for years, but doing it for the right reasons. But it's not easy work. I've done it before, and we'll need to do it again here. And I think that gives us an opportunity to reduce our cost structure. We're going to have to. We're going to be committed to trying to figure out how we can change our revenue to the organization. So, for example, we've recently partnered with an organization called Agilon, which will help us provide better care for Medicare Advantage patients. And we will get paid financially through our relationship with Agilon if we do things like reduce hospitalizations, reduce ER visits, and provide better medical management to those patients. And it will come at the expense of fee-for-service revenue that we will lose. So as we think about how we transition our business model to try to do things differently, to receive payment for doing the things that are aligned with doing the right thing for patients, I think we're going to have opportunities to make incremental investments in how we deliver care in our rural communities. Our rural communities need us to do that. They need us to do that in terms of being able to deliver better care closer to home, which we ultimately think will help reduce overall healthcare expenditure versus trying to transfer patients just to Portland, and at the same time help us produce better outcomes. The incremental investment in trying to deliver that care in our rural communities is largely small because most of that is not bricks and mortars and buildings. Most of that is just in personnel and training to ensure that they can safely deliver care in those communities. So I think our cost savings opportunities are reasonably large. The investment opportunities to deliver some of that care are relatively small.
May I follow up, Madam Chair? So I guess, so over the years, Maine Health has bought up a lot of small independent practices. And I'm just wondering, out of curiosity, for my own sake, are we starting to create a monopoly here?
Yeah, I certainly don't think so in terms of healthcare expenditures and share of wallet in the state. We're nowhere near monopolistic in terms of size relative to the other large integrated healthcare delivery systems in the state. And at the same time, too, not all healthcare is delivered within the borders of our state. We have lots of outmigration to other areas. So our intent is not to grow any larger. We've talked about that internally as a team. We don't think that's the right strategy for us. The right strategy for us is to deliver better care, improve access, make sure that we're effective in terms of working toward health equity. Those are the things that we think we need to be focused on in the short term. I spoke to the board of the Maine Medical Association last night and was very declarative in saying, we don't want to purchase your practice. We want all of you to remain in independent practice, and we need you to be viable and successful. That's better for all of us. As I've had conversations with other healthcare system leaders in the state, it's the same message. We need you to be successful. If you're not successful, it's going to put more burden on us at a time where we're struggling to meet the demand for all of the services that exist today. So we don't intend to continue to grow. That's not our intent. Our intent is not to try to create leverage with what we have. We want to be responsible and ultimately achieving our vision of working together so our communities are the healthiest in America.
Thank you.
Representative Matheson.
Thank you, Madam Chair. I had just a few questions. Thank you so much for being here. I own a small medical clinic, private medical clinic that does IV therapy. So I'm certainly aware of the challenges of trying to negotiate rates and changes in policies. That being said, I just had a couple of clarifying questions. I just wanted to make sure I understood that settlement, those settlement payments, that is not part of the 120-day 70 million that's outstanding. Is that correct? The 42 million, that's an older settlement payment that you're awaiting. Is that correct? That's not part of the 70 million. I'm not sure about those numbers.
Yes, no, it is part of the 70 million, and it represents amounts to be reconciled from our fiscal year 2020 and fiscal year 2021.
Okay, thank you. When were you notified of this policy change? I get a little bit confused because it sounds like maybe the contract was signed with this information in the contract, but yet this policy change of only billing one procedure a day seems to be a new policy. So when were you notified of that?
It's my understanding we were notified of that in January of 22.
January 22. Okay. And I'm just curious, in terms of some of the 3% margin, which is unfortunately 2 or 1 or negative, which I could completely relate to.
Sure.
I'm curious, how much of that have you put into trying to get a system that has some more cost transparency for people who are using your services? Where are you for that for Maine Health? That's certainly a complaint that we hear in terms of hospital costs. So where are you for Maine Health in trying to help that?
I'm happy. Yeah, so we are compliant with the latest federal regulations on publishing on our website access to our listed charges, also the amounts that are paid by commercial insurers. And if I may, Representative Matheson, I'd like to just clarify Andy's answer, if I could, around the policy. The policy went into effect in January, so we've been seeing those additional denials since that date. I think the date on the policy is back in April, just about a year ago. We formally objected to the implementation of that policy through communication to Anthem sometime in the fall of 21.
Thank you very much.
Okay. Not seeing additional hands raised from the committee. I have some questions as well. There was discussion about $1 million a month or just over that at MMC itself being withheld. I am trying to understand which bucket of costs that fits into, whether those are the disputed payments, whether this is related to 340B, or what it's related to. If you could help me understand what that withholding is.
Al, I'll let you start with that.
Sure. So that amount represents an additional discount that Anthem was compelled to take starting last August, because they believe that Maine Medical Center had increased its rates beyond what was permitted in the contract that we had signed back, and actually it goes back to 2016, and they've carried that forward to implementation in 2021, in August of 21.
I'm sorry, can you explain that a little bit better? I'm not sure I followed what you just said.
Certainly. In provider and payer contracts, we negotiate rates to be paid and also may negotiate rates of future increase. Anthem believes in their so-called routine audit that they discovered that Maine Med increased its rates in 2017 over the amounts in 2016 by more than what the agreed upon rate increase should have been. They then, because of that, increased their discount or decreased the amount of payment to Maine Medical Center by 4.24% beginning in August. So that has become now part of our revised payment rate as instituted by Anthem. That amount is not included in the 70 million that we're describing. So this is an ongoing issue in addition to that.
Okay, that's helpful. I was trying to figure out if the 70 million was an accumulation of 1 million a month going back 3 years or what it was.
It is not. Candidly, we're not even sure how the period between 2017 and 2021, when Anthem made that change, how they intend to address that issue. we do not believe at all that there is an issue to be addressed in either of those cases.
Okay. I understand, or I thought I knew, that there was some negotiation in the last contract round with Anthem related to using Medicare as benchmark rates and having Medicare Plus as a tool of negotiation with Anthem. And I have a vague recollection of a discussion about that back when we did meetings in person. So that would have been probably 2019. Can you speak to whether there's Medicare Plus charge negotiations as part of the contract, or I thought that was part of what was going on.
It may have, frankly, I don't specifically recall that we had talked extensively about building our payment rates off of a Medicare base. It's not uncommon for current rates to be converted and used in a reference way. And it isn't uncommon that there may be some providers who accept that. And in fact, it's quite common now on a physician basis, perhaps not as common on hospital procedures. But our current contract, the one we signed in 2021, does not include a reference-based pricing to Medicare.
Okay. And so the one in 2021 includes a reference to Charge Master from 2016. Is that what you're indicating?
Yes, let me clarify. The 2021 agreement was an amendment to an original 2016 contract. So the terms and conditions of that original contract in 2016 have continued forward with each successive amendment to that original contract. And I think off the top of my head, I think there's been at least 2 additional amendments from that original contract.
Okay. And so then 6 months after this most recent amendment was signed, there was an audit that suggested that in 2017, the charges at MMC were raised too much.
Correct. That's what's being purported by Anthem. Yes.
Okay. And
we disagree.
All right. Are 340B medications involved in that, or is this unrelated to 340B?
One of the areas that Anthem has pointed to for their reasons for increasing the discount or paying us less in 2021 is pharmacy. The other area specifically is supply charges. In pharmacy,
I'm sorry, supply charges.
Supply charges.
I'm not a healthcare person. Can you tell me what that means?
So supplies that might be consumed in the course of care. So
like the tubing. Yeah.
Yes.
Okay.
Yes. Things like that. Yes.
Band-Aids.
Yeah.
Usually it's more substantial than that, but yes. So in trying to explore with Anthem their justification for the reduction in pharmacy, it fell back to the only plausible reason, which seemed to have been reliance on what would be our benefits from the 340B program, and that they should be passed on to a commercial payer. If that were the case, it would certainly negate the whole purpose of that federal program, which is to support hospitals who are caring for populations that are really economically challenged in a disproportionate way.
Okay. So that may be part of their rationale.
Yes, and I don't believe I could address it any further since it's their position.
Understood. I'm just trying to get a handle on, when I think about the negotiations, I'm thinking about the charge for a procedure, but it sounds like they're not saying those went up too high. They're saying it's the supply charges of the pharmacy, which I would think are largely pass-through charges with some sort of margin added to them. Is that accurate?
Not necessarily.
Okay. You don't want to elaborate on that?
When we look at our management of a charge master and the prices that we establish, and then we look at a negotiated level of increase year over year, we would look at what did we charge in one year and what did we charge in the next year to comply with that term of contract.
Okay. So if the underlying cost of the medication went up more than the allowed increase, you would not be able to pass that along to the payer.
Actually, that's an area that we would like clarification from Anthem on their expectations.
Okay. All right, Representative, I'm going to go to Senator Brenner first because she hasn't spoken yet. Go ahead, Senator Brenner.
Thank you, Madam Chair. Thank you, Dr. Mueller and Mr. Swallow for being here. I'm wondering, you spoke a little bit about the importance of your talent at the hospital and also of investing in communities. And I see your talent as investing in your talent as an investment in community. Can you speak a little bit about where you are from an administrative perspective on the collective bargaining agreement with the nurses union?
Yes, we've had well over 20 bargaining sessions. We've made good progress on a number of key items. We have a couple of more outstanding items with future bargaining sessions scheduled. We truly respect the decision of our care team members to organize, and we want to make sure that we partner well and effectively with them and their union representation.
When do you have a goal internally for when you hope to have that agreement finalized?
I don't participate in the discussions myself directly. We can get you information on sort of what is the schedule for the upcoming bargaining sessions for sure.
Thank you.
Representative Tepler, go ahead.
Thank you, Madam Chair. And thank you again, Mr. Mueller and Mr. Swallow for being here. I'd like to go back to the issue of supply charges just for a minute. I'm understanding the situation in terms of pharmacy and the 340B program, but I'm a little, I have a few questions about how the supply charges work. Do you apply, in fact, a percentage on top of cost for supplies when you bill it? And if so, has that percentage changed? Or does it simply reflect increased costs?
For the most part, when we bill for supplies, if it's a new item, we will establish a markup on top of that cost to establish the new price for that item. And then year over year, we would apply the incremental increase to that previously charged price. So for example, if we negotiate a 5% price increase with a payer from 2016 to 2017, we would apply that additional increase to that price. And if a new item came on, the markup would have been increased by that same incremental markup percentage.
And if the cost of the supply item rises, then you are not increasing above that agreed upon margin regardless of the cost?
We are not currently, but I would again say it's not clear to me what Anthem's expectations are around that.
And your markup varies contract to contract?
No, one thing about hospitals is our charging structure has to be consistent across all payers, regardless of what the payer is paying us.
Okay, so what is the markup on supplies?
It's probably in the neighborhood of 3.5 to 4 times the cost from us from our vendor.
Thank you.
And to be clear, I'm describing Maine Medical Center in this specific circumstance. It certainly would vary hospital by hospital within our system.
Sorry. Go ahead, Representative Evans.
Thank you, Madam Chair. Just to follow up on what Representative Tepler was talking about, the question she was asking. Since 2016, the do you know the average rate of the cost of pass-throughs? How high has that gone from year to year?
For our negotiated rate increase with Anthem year over
Yes.
year, it would be approximately in the 4 to 5% range for each of those years for Maine Medical Center.
So is that in dispute at this point?
No, I think it's the application of that increase that I would describe as perhaps being in dispute.
Clarify for me when you say the application.
I think the number itself, what we negotiated, is clear in the contract. Anthem believes that we may not have complied with that in the way they believe it should have been complied with. It may be related to whether it's on markup, before markup, costs that may have been revised on the underlying cost of something on a supply side. Again, that's not clear to me what their expectations are.
Okay, thank you. Thank you, Madam Chair.
And
Thanks,
I would just
Representative.
add, these are things that we've been trying to address through the mediation.
Okay. Go ahead, Representative Arford. I see a new hand. Go ahead. We can't hear you. I'm not sure.
Oh,
There you go.
Thank you, Madam Chair. And I would also like to thank Mr. Mueller for being with us today. And I do understand and appreciate the complexity of this issue. I have a rather simple question. It's not that I'm confused. I just want to make sure that what I understand is correct. In Maine Health's decision to remove Maine Medical Center from Anthem's network, is it true that this does not include emergency room services, that it includes hospital services outside of the emergency room and also outside of your physician practices? What is the extent of your decision to withdraw from the Anthem network? That's my first question. Then I have a quick follow-up one.
You bet. I'll start and then let Al correct me if I don't get this correct. Our decision was to remove the hospital services of Maine Medical Center from the Anthem network. So first of all, any patient can be seen at Maine Medical Center. If they have emergency services at Maine Medical Center, under law, Anthem has to consider that patient as in network, even if we don't have an active agreement with Anthem. There are going to be some services that we're the only, that Maine Medical Center is the only hospital in the state. And I'm thinking about things like level 1 trauma, which is emergent, and some advanced pediatric services for which the Bureau of Insurance may deem Anthem has an inadequate network in the state. And so for those services, those patients could be considered in network at Maine Medical Center for that care. Our physician practices are not part of this. So if you've had a long-standing relationship with a Maine Health physician, you should be able to continue that at in-network rates beyond the termination date of 1/1/23.
So, and my follow-up question is, do you see that this will though spread? Because as you've mentioned in your testimony, does an excellent job of outlining the extensiveness of the Maine Health network. Do you see that the need to remove other parts of the Maine Health network from the Anthem network that will continue over time?
We certainly hope not. It was not our intent to want to remove the Maine Medical Center from the Anthem network, but felt that we really were in a position where we didn't have any choice. And so our intent is not to give notice on any of our other healthcare delivery functions beyond Maine Medical Center, but to a degree, the ball is in Anthem's court on how we're treated at those locations as well.
Thank you very much.
Okay. So as I've been listening, I think there are three different buckets of unpaid or disputed claims, and I just want to make sure that I'm understanding them because I think they're quite different from one another. So I think there's the 2 years behind on settlements that you mentioned was $42 million in your view. There's policy changes or disputes leading to non-payment of disputed claims, and I did the math, that seems to be $28 million. And then there's an ongoing $13 million a year that stems from a 4.25% reduction at MMC's payments specifically. Are those the three buckets or are there others?
Madam Chair, as it relates to the claims or the dollars in dispute, I think that's accurate. But I do want to reemphasize the more significant issue that's led to this and ongoing is the term in the contract and Anthem's approach to making changes on their own about how we get paid today and in the future. So it's not just about the money, it's about the way that they implement changes that impact what we believe we had negotiated for payment.
Okay, so one of the policies that I expect we'll hear about this afternoon when we turn to public comment is the algorithmic downcoding and the recharacterization of claims. Is that one of these policies that Anthem has changed unilaterally in the contract over the last year?
Candidly, I'm not fully aware if that is an actual contract policy or just a payment approach that they're taking in processing claims. But we have seen that in our organization specific to Medicare Advantage claims. So we have experienced that.
Okay. Representative Evans.
I think that he just answered my question. Thank you.
Okay. And to what extent does this dispute extend to Medicare Advantage? Are they covered under the same contract, or is it a separate contract and therefore a separate dispute?
A separate contract, and those patients at present are not impacted by this.
Yeah, again, let me try to clarify here that even as we own a joint venture together, Anthem and Maine Health, that covers Medicare Advantage patients, a relationship we developed in order to participate in a way different than straight fee-for-service, as Andy had noted earlier. Within that arrangement, our participation as a provider actually comes through our existing Anthem provider agreement. We limited the termination notice under that agreement to be only the commercial side. So technically it is through the same agreement, but we committed to continue to participate in that joint venture that we share with Anthem in the Medicare Advantage program. Sorry, I'm sorry for the additional complexity there, but that's, I think, important to understand. So to be clear, our intent is to continue to have Maine Medical Center participate as an available provider post-January in the Medicare Advantage program.
Okay. And you mentioned in response to one of my colleagues' questions that there would be certain services at Maine Med that would have to remain in the Anthem network because the only place they can be obtained. Am I framing that correctly? And that's certainly a topic that we will discuss more with the Bureau a bit later, but could you speak to Maine Health's understanding of what that means?
Go ahead, Al.
Yeah, so I would think, as Andy answered previously, there's a part of this that's covered by law, and there's a part of this that I think is through regulation of the insurance companies through the Bureau as to what may be deemed an adequate network to serve the individuals they have rolled in their insurance products. And so we have asked both Anthem and the Bureau that we're to work together, all of us, to understand what services they might classify in those categories. When Andy's describing, as he did, what we think might happen, we're sort of speculating based on our limited understanding of how the regulations may be applied and just knowledge about where services may or may not be available in the state of Maine.
Do you anticipate that under Maine's regulations, you will be paid more for the services that are necessary, medically necessary to continue to be covered by Anthem, because they will not be governed by the contract, but by default payment rules instead?
When we inquired about how we would be treated and paid under that, I would say this answer isn't clear, but former Superintendent Chopper informed us that he believed that our charges would be recognized and that the charge amount would have to be considered by Anthem in processing deductibles, co-insurance, and things like that. But I would
So
also
you would
say,
you would stand to make a lot more money
no, yeah, so
on
let
those
me,
necessary services if they're not considered in network.
we could very well be paid more for those under the law. I would say we're willing to talk about that issue, including with specific employers, if that's something that we need to do, if we don't get to a place where we can resolve this together. That is not at all our intention to try to maximize a payment on a limited number of services for which we would be available.
We did not enter into this in any way, shape, or form to create financial gain for us. That's not the intent. And we're willing to do what it takes to ensure that we're adjudicating claims in an appropriate manner that doesn't disadvantage employers or patients.
Right. Okay. And of course, not all employers are in a position to be able to negotiate with you directly. Those in the fully insured market would not have access to that sort of disparate treatment. Isn't that right?
I believe that's a fair review, yes.
Okay. Representative Matheson.
Thank you, Madam Chair. I have to say, I'm seriously concerned about the consumer after hearing some of the conversations about if this goes through, what services will or will not be covered. It'll lie on the consumer in trying to fight whether or not they were considered an emergency admission, or if they are having such and such procedure, part of it might be covered, part of it won't be covered. So we don't know how transparent the costs are going into an emergency room visit. Then we're transferred to the hospital and several procedures are done in the hospital. Those aren't covered, but the emergency part was. I'm very concerned about the consumer. And I feel like that's getting lost in this conversation with all of you. I know that you're saying that you care about the consumer, but this really makes me extremely concerned when I hear that there are certain services that will still maybe be covered, maybe not. It puts the emphasis on that patient that's sick that has to advocate for themselves. And I'm only making that statement because it's very frustrating to me.
Yeah, no, Representative Matheson, we certainly appreciate that perspective. I will say that part of the reality that we face today is that we're challenged with that in the current environment, even with negotiated contracts, and it comes back to prior authorizations in some cases. So I wish I could tell you that it's perfect even when we are in network with everyone, but it's not, even with everyone working hard to try to get it right.
Representative Evans, go ahead.
Thank you, Madam Chair. One final question for me is, I am hung up on, to echo what Representative Matheson said, I think that she's right on spot with that. That's, even though the physician practices may not be affected, it goes beyond there. And that puts a break in the continuity of care between a physician's office and getting somebody in the hospital. But that's that bothers me as well. But the other thing is, the contract, when are you notified when there is going to be a policy change from the insurer? Do you get an advance warning? How has that been handled?
Yeah, last year legislation was passed that required advance notice of providers, and we have had the opportunity to write objections to that. Anthem's acknowledged receipt of those objections, but there's been no opportunity to participate in any dialogue around changing them.
How often do they occur? Say if you get one or two a year or what?
No, there's been several hundred policy changes over the past 2 to 3 years. I think the number is roughly 60 that have been reimbursement type impacts.
Thank you.
Okay. I think with that, we will thank Dr. Miller and Mr. Swallow for joining us this morning and presenting this difficult issue for us. I'm going to move you folks back over to the attendee space, and we are going to hear from Anthem. We have Denise McDonough and Chris Ossenfort with us from Anthem. So I'm going to move you back over now. Thanks for joining us this morning.
Thank you all for your time today.
Thank you.
Okay, the folks from Anthem are joining now. And just so folks know, I anticipate we'll hear from Anthem and then we'll take a break for a short time. So everyone can grab what they need at that point. Okay, good morning, Ms. McDonough. It's Ossenfort, nice to see you. Please go ahead and introduce yourselves and present for us your briefing.
Great, good morning. Are you able to hear me okay?
Yes.
Okay, great. Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage, Insurance, and Financial Services Committee. My name is Denise McDonough, and I'm the president of Anthem Blue Cross and Blue Shield in Maine, a domestic health insurer licensed by the Maine Bureau of Insurance and headquartered in South Portland, employing nearly 650 Mainers. Our plan has been serving the people of Maine for 84 years, and all of us at Anthem Blue Cross and Blue Shield are committed to providing the over 300,000 members we have to high quality and affordable health care. I'd like to thank you for the opportunity to address the committee today and to share our perspective on this matter. Mainers are experiencing an increase in healthcare trends that is not sustainable. Our customers and our members depend on us to help them access the services they need while maintaining affordability. Anthem and its provider partners have a collective responsibility to achieve that, and we remain committed to the mediation process that began last fall and to resolving the current issues with Maine Health. At the outset, let me just acknowledge that we are not perfect. Anthem has had operational issues that have resulted in provider dissatisfaction. We've been working extremely hard to address those issues and have made significant progress in doing so. As an example, we created a
Ms. McDonough, you seem to have frozen. It may be helpful to turn off your camera so that we can hear you better.
Maine Health has attempted to use those operational issues to its advantage.
I think, Ms. McDonough, you were frozen for a good 10 or 15 seconds there. So maybe back up what you were saying by a sentence or two, because I think we missed something.
Okay, am I back clearly now?
You are at the moment.
Okay, all right, let me know. Thank you for letting me know that. I'll just back up a couple of words, of sentences. I want to acknowledge that Anthem is not here to say that we are perfect, and to acknowledge that we have indeed had operational issues that have resulted in provider dissatisfaction, and also that we continue to work extremely hard to resolve and address these in full and have made significant progress in doing so. And by example, we've created a dedicated line for Maine providers to call us with dedicated people in Maine for Maine providers. And the folks should feel free to call that number for any assistance they need with any of the claims or other issues they're experiencing. We will resolve them, and we will resolve them in full. And we are committed to regaining the trust and the confidence of our provider partners. Unfortunately, though, Maine Health has attempted to use those operational issues to its advantage in the media by suggesting that we owe them $70 million in unpaid claims. And this is extremely misleading. Anthem pays Maine Health on a prospective basis. You heard a little bit about this earlier, meaning we pay Maine Health in advance every week based on anticipated volume, and we reconcile those payments at the end of the year based on the actual claims submitted. Therefore, any claim payment issues that might exist do not have a material financial impact on Maine Health's cash flow, as it receives this fixed amount each week in advance. As a result, Maine Health has been largely unaffected by our claims payment issues. The real issue between Anthem and Maine Health is the result of Anthem having discovered that Maine Health is materially overcharging Anthem and its members. A hospital charge master is a hospital's price list for its products, its procedures, and its services, everything from surgeries and patient rooms to prescription drugs and supplies. And in 2018, Anthem discovered that Maine Health had been overbilling for anesthesia and operating services through increases to its charge master that were not authorized under the contract we had with them. I'll refer to that in my testimony as Charge Master 1. After many months of denials and refusals to provide the data to us that was required under our contract with them, Maine Health eventually acknowledged the overcharges and refunded nearly $20 million to our customers. As a result of Anthem's efforts, we believe this may also have resulted in millions of dollars in refunds to other carriers in Maine and their customers. In 2020, Anthem identified additional billing improprieties, including that Maine Medical Center had been overcharging our members for drugs and for room and board, the combination of which resulted in an overcharge of more than $50 million. I'll refer to that as Charge Master 2. Given that Anthem only represents 1/3 of the market, the overcharges across the Maine market could be as much as $160 million or more. And it's important to note that this estimate does not include any potential overcharges of the uninsured. We firmly believe that we are correct about the overcharges in Charge Master 2, just as we were correct about the overcharges in Charge Master 1, which resulted in the refunds I mentioned. When Maine Health disagreed with our finding, we asked it to provide us with the data to support its position. Maine Health has repeatedly refused to provide any data to justify or explain their increases. As a result, we implemented an offset or a reduction to adjust for the overcharges going forward beginning April 1 of 2021. In October of 2021, we entered into mediation with Maine Health to try and resolve the Charge Master 2 and other issues. Because we've been attempting to resolve these issues since last fall through mediation, we were surprised and disappointed when in March of this year, Maine Health notified us of its intent to pull Maine Medical Center out of our network in January of 2023. Even so, we continued in our efforts to resolve the issues with Maine Health through mediation. We even agreed to a 30-day period during which the two companies would focus on resetting our relationship in a more collaborative manner and finding common ground. In fact, we were focused on the very things that Andy Muller discussed in his comments earlier around his mission to make our communities the healthiest in America and transforming our system. So we were shocked when in the midst of that 30-day period and ongoing mediation, that Maine Health decided to publicly announce its intent to pull Maine Medical Center out of the network on January 1st. Maine Health has made this dispute public in order to create chaos and confusion and to scare Anthem members in order to gain more leverage in the ongoing mediation. Maine Health is able to do this because it's a monopoly that provides essential healthcare services and one that is largely unregulated. While Anthem's individual and small group rates and business practices are regulated and overseen by the Bureau of Insurance, no one is regulating the prices or the business practices of large healthcare systems like Maine Health. And as this committee is aware, Anthem is subject to network adequacy requirements. Maine Health knows this too. Maine Health is seeking to force Anthem to acquiesce to its demands and to use our members and its patients as pawns in its negotiation by choosing to publicize its decision many months before the termination would occur, rather than committing itself to mediating in good faith. Since making the dispute public, Maine Health is now coming back to Anthem with new and unprecedented demands that were previously not even raised in the mediation itself. Those include renegotiating our existing contract with them that is in place, as we heard earlier, through September of 2024, significant rate increases for all Maine Health hospitals, including, in addition to the already above market rate increases that Maine Health will receive under its current contract with us. They're asking for the ability to bill services through any Maine Health entity, regardless of where the services are actually rendered. And they're demanding a prohibition on Anthem implementing any policies for the protection of its members. By way of example, Maine Health currently bills for services rendered at Midcoast Hospital as though they had been rendered at the more expensive Maine Medical Center. This has resulted in Maine consumers paying 40% more than if they had been billed as required through Midcoast. One of Maine Health's new contract demands would allow Maine Health to continue with this practice, and Anthem would be unable to stop it. If Anthem agrees to Maine Health's demands, the resulting contract would be extremely harmful to Maine consumers and businesses, and in fact, would be the worst, and by worst, I mean the most consumer unfriendly contract in all of the 14 states in which Anthem operates. We believe these new demands, which had not been raised in nearly 6 months of mediation, are the first step toward Maine Health threatening to pull all Maine Health providers out of our network. Unfortunately, this is a tactic that we have not seen them use before. Maine Health can make these demands because it has achieved a monopoly status, owning most of the hospitals in the southern half of the state. This gives it enormous leverage because, as noted before, Maine Health is well aware of the network adequacy standards with which health insurers must comply. Anthem is charged with protecting our customers by maintaining affordability. But even the state's largest carrier cannot negotiate effectively on behalf of our members with a system as large as Maine Health. Because of its size, Maine Health can, and it has, insisted on above market rate increases that result in strong financial results for Maine Medical Center that are out of step with other nonprofit hospitals in Maine. Those high costs are ultimately paid by Maine consumers in the form of higher premiums. This also results in fewer healthcare dollars available for other smaller hospitals that have greater need. This is a long-term problem, which, if it's not addressed, will continue to result in healthcare cost increases that far exceed general inflation, making healthcare and health insurance increasingly unaffordable for all Maine citizens. So where do we go from here? We remain committed to trying to resolve these issues, and we hope that Maine Health will partner with us to reaffirm a mutual commitment to the customers we serve and to work with us to both ensure access and affordability. But we are also engaged in contingency planning to prepare for the possibility that Maine Health will make good on its threat to pull the Maine Medical Center from our network. Either way, we are committed to ensuring that our customers continue to have access to high quality healthcare that we know that they need. I appreciate the opportunity to share these comments, and I'd be happy to answer any questions you may have.
Thank you, Ms. McDonough. Are there questions from the committee? Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. McDonough. Ms. McDonough, is there any other tertiary care hospital in network for Anthem patients in Maine?
Well, Chris, do you want to take that? I mean, yeah, Chris, why don't you take that for me?
Sure. Thank you, Representative Tepler, and Chris Ossenfort, Government Relations Director for Anthem Blue Cross and Blue Shield here in Maine. There are other tertiary care hospitals in Maine, including Northern Light in Bangor and Central Maine Medical Center in Lewiston.
Follow up, Madam Chair. Are there any hospitals out of Maine that are in network in some plans?
Yes, we do have some New Hampshire plans in network. It also depends a little bit on the plan design. But this year, our individual plans also include access to hospitals in the New England region. Previously, they didn't have any out-of-state benefits, but they do now have access to hospitals in Boston as well as the other New England states.
So that is for people who have purchased plans, ACA plans at the silver level and above?
At any level.
At any level. Thank you.
Representative Evans, go ahead.
Thank you, Madam Chair. This could be answered by either person. How does the increases in the Maine health prices compare to, just say, New England in general? Are we seeing similar price increases as demanded by Maine Health? Is this just a local thing?
I'll take that, and Chris can expand if she wishes. I would say that both historically and currently, we are seeing demands from Maine Health that are not consistent with demands that we are seeing from other providers here in the state or outside. And as I mentioned earlier, the current demands being made would make it the most non-consumer friendly contract we hold here in Maine and outside. So I would say that is a trend that we have experienced with Maine Health for many years, and it is a trend that they continue to try and require of us.
Okay, if I could follow up on you, in your earlier comments, you mentioned the fact that you did have operational issues, and there was provider dissatisfaction, and you have a dedicated line for physicians. I am in solo private practice of general surgery, and just speaking as an individual in that regard, it is often extremely difficult to get direct contact and information for a patient that I may have. It seems like you're on a rotary dial, and a lot of times what you end up getting is someone on the other end of the phone who is making that decision. They're making a medical decision. It may not even be in their realm. They may not even be physicians. I think that going forward, despite what's happening now, we have a real big trust issue, I think, on both sides. So I just wanted to mention that.
I appreciate that comment. Thank you. And I agree that we have to work harder to restore trust and confidence with our providers. The providers who have been, most impacted by some of the operational issues have been the individual and smaller practitioners and practices, particularly those who are not on the PIP program that were discussed earlier. Notably, but not entirely limited to the behavioral health providers and some of the individual smaller practices, be they chiropractic or osteopaths, et cetera. Those are the providers that we really have focused on trying to restore their confidence for those that have made decisions to consider leaving the network, to work hard to restore that confidence, to retain them, and to ensure that we are paying them quickly and accurately, and to restore that timeliness that we have always been known to have. And we are there. We are very close to getting back to entirely the turnaround of our claim timeliness that we had sort of pre-system migration, and when we started to run into some of these issues. So I appreciate your comments, and I fully agree. And we are committed to restoring the confidence that you alluded to having lost in us.
Thank you.
Representative Connor, go ahead.
Thank you, Madam Chair. Thank you, Ms. McDonough and Ms. Ossenfort. Mr. Mueller talked a great deal about revenue, and he mentioned that you guys are $140 billion revenue. Can you speak to that a little bit? Is that just in Maine? Is that the national? Is that cumulative for all of Anthem, or can you just speak to that a little bit and tell us what we're hearing a David versus Goliath, but I'd like to hear from you guys on that.
Yeah, I mean, I think I would just say there's no contesting that we are two very large organizations. I would dispute Andy's comments that they are not a giant on their own. We are two very large organizations. There's no question about that. I think the point I'd like to make, at least initially here, is to remind folks that number one, we are our large parent company is in fact a publicly traded company. That's not a secret. But as such, we provide a great deal of transparency regarding our financials. In addition, we are regulated. Anthem Blue Cross in Maine, the organization that we're really here to talk about today, is a regulated entity, which by law requires us to spend a mandatory percentage of our dollars on the administration of benefits and on claims. And if we spend more than that prescribed amount on the administration component, we must reimburse our members directly. So I come to that because we've said it a few times, we are highly regulated, and there is protection for our customers that comes with that regulation. And it is not something that we can say is true for Maine Health. And so, I think we're both very large organizations. I think we're here because the state of Maine needs both of us to do our jobs. And, I think we need to get back to the table and talk less about how big we each are or what our margins are or how much people are making, because while that can be the topic of conversation, it's frankly not what we're here to do to resolve this issue. We need to get back to the table, and we need Maine Health to do that in a more meaningful way with us.
Representative Matheson, go ahead.
Thank you so much. I just wanted to get some clarification on the new policy that was put in place from Maine Health's perspective around not billing for more than one procedure in a day. That seems, from a healthcare provider who owns a clinic, that seems a little strange to have that policy show up in the middle of a contract. So could you just discuss that in a little more detail from your perspective?
Sure, that's not the policy. We do not say that two procedures cannot be done in the same day. It's often appropriate to do two procedures in one day. You've got the patient there in the hospital on the bed, and it makes sense to do that when appropriate. I don't think anyone would dispute that. What we're doing here is we are reducing certain components of the payment where there are redundancies. Because for the very same reason that it makes sense to do two procedures potentially in one day, because we don't want the patient to have to come back another day for anesthesia if it can be done in one. But there are duplications of services in some components of those procedures. And those are the areas, these are specific line items that are duplicative, that are being removed from payment. This is, by the way, a practice that is done by all carriers and also by Medicare and Medicaid as well. So I think it makes sense on the surface it's the same bed. We're not going to be charged for 2 beds. It's many of the same duplication of services, but there are certainly services, many of them, that are reimbursed for, as you would expect they should be. And those are absolutely being paid for. So to suggest that we're not paying for a second service is just not a true statement.
Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you again, Ms. McDonough. I have 2 follow-up questions on what my colleagues have previously said. As far as the redundancies being removed from the bills, is there anything new in that policy that Maine Med is hanging their hat on, or is that the same thing that you've been doing all along? Is there some kind of change?
Honestly, I don't know that I can answer that. This is a policy that I believe Anthem has upheld for a number of years. Whether there was a modification to a policy like this, I don't know the answer to that. I'm happy to follow up with you on it. If I could just expand on your question a bit, I think what's important here is to make sure that folks are aware these types of policies. Andy Mueller had made a statement earlier that, and Al Swallow, that we are mid-contract changing the monetary reimbursement, the amount of money that we are paying Maine Health for certain services mid-contract. That is not true. We agree to a certain level of reimbursement, and that is honored for a contract period. What we're talking about are policy changes that are there to ensure that providers are billing us accurately, properly, legally, et cetera. And so these are examples of policies that have always been in existence for all carriers, including the government carriers. And so this is not something that Anthem is doing differently, and I felt as though it was represented that way. We do them when we see new examples of things being done by providers. We feel the need to modify policy to try and ensure proper billing for our consumers, for our members, for our customers. And these are examples of those things that occur with notice, as you heard earlier, and with the ability to discuss and modify. We have made modifications to several of these policies over the last year because we know we're not perfect. And when we introduce a policy, there can be unintended consequences. So we have made modifications to several of these policies over the years as we've evaluated and analyzed and determined that there were unintended consequences. But they are an essential part of any carrier trying to ensure proper billing and protect customers from inappropriate charges.
I understand what you're saying, Ms. McDonough. I would, however, appreciate knowing exactly what the modifications were within the contract period. Thank you. It would just be helpful to understand. And my other question is, Representative Connor asked you about the $114, I think, $million. Is that correct? Yes, that $114 billion, sorry, profit. And I would like a little bit more information about that. Is that all of Anthem, or is that Anthem of Maine that we're talking about? And I know you're a publicly traded company, so you do have to report your profits. And so that's public information, but we don't have it. So it would be helpful to have it.
I'm honestly not sure where that number is coming from. So Chris, I don't know if you know where that number might have been pulled from or what it's even pertaining to.
No, Representative, I don't know where Maine Health got the number, but I can tell you that is not Anthem Health Plans of Maine.
No.
Okay, could we get information either today or in writing about what the publicly traded company's profits are?
Yep.
Thank you. That would be helpful.
We can certainly provide that, Representative, but I would note that Anthem Health Plans of Maine is the entity that has to be financially solvent in Maine, and our claims have to be paid by the premiums we receive, not by any influx of monies from our parent.
Yes, I do know that that's true. Thank you, Ms. Ossenford. And I also know that you have a medical loss ratio that you have to comply with as well. Thank you.
Representative Arford.
Yes, thank you, Madam Chair. And thank you, Ms. McDonald, for being here with us today. I have with me today a letter that was shared with me by a constituent that they received from Maine Health. I'm sure you've seen this letter, explaining why Maine Health is choosing to withdraw all non-emergent Maine Medical Center services from the Anthem network starting in January of 2023. And the letter, in a very simplified terms, goes over much of what we've heard this morning. However, there's one statement in the letter we have not yet discussed that I would much appreciate your comment on, and I will it's a brief statement. And it states, while the insurer has said publicly that it is fixing its systems and putting its problems behind it, that has not been the experience of Maine Health. Last week, the Georgia Office of Insurance and Fire Safety fined Anthem $5 million for practices similar to what Maine Health has experienced. And if you could comment on that, I'd appreciate it.
Yeah, I mean, I'll make a comment, and Christine may have something as well. I mean, I think a couple of things. We are distinctly separate organizations in many ways, and we have different challenges and different obstacles that we are facing. Just like Maine Health described to you the many challenges they have faced during the pandemic, we have faced many ourselves, as we all have in our respective businesses. And so, you know, one of the issues that you're hearing about in some of the states are some of them are unique to their own states, and some of them are similar. And so, you know, I think it's important to realize that this is not a systemic Anthem issue. We have been in the state for nearly 100 years, and we have been, I think, an extraordinarily good partner to our providers, to our hospitals, to our customers, and we've not had a history of these types of issues. These are a combination of problems, some of them pandemic related, some of them are system migration related. That is largely what has created many of Anthem's claims delays. And some of the other Anthem states have shared some of those same issues, and some have had different issues. So I would just say this is not a systemic issue. I think you have all been, you know, here in Maine for enough years to know that this is not a conversation that we've had to have routinely with Anthem of Maine. We are here for the long, and we've been a historically very good partner. We are, to the comment that you just read, it's not true, because I see the progress, I see the claim payment metrics. We are paying our claims very properly. I think we saw that in one of the testimonies this morning that were posted. We are back to paying our claims at normal levels, and we will continue to resolve the many other issues that we have worked hard to resolve as well. I'm not saying that we are through all of it, but the claims are back being processed rather quickly, back to normal times, and some of these other issues that persist will be resolved as well. Chris, I don't know if you have anything you want to add to that as well.
I just want to clarify what by the way, thank you for that. But when you said it's not true, are you saying it's not true that the Georgia Office of Insurance and Fire Safety fined?
No, sorry, no. That is true. I was responding to a couple of different points of that sentence that you read. One of which said something about us not remedying our problems and solving for some of the claim delay issues. And at least as it relates to Maine, that is not a true statement. I can't speak for the other states in terms of exactly where they're at for their claims processing.
Thank you.
And Representative Arford, with respect to the Georgia fine, I think it's important to note that involved a system that was a provider database system that was being used in Georgia about 7 years ago. It's no longer in use, and it was never used in Maine. So I just wanted to provide that clarification as well.
Representative Morris, go ahead.
Thank you, Madam Chair. A little different doing it in person here. It seems like a lot of the issue that Maine Health is raising deals with a lot of these mid-contract policy changes. As you know, we did have pass some legislation last year dealing with the communication of those things, but I wonder if you could just touch on a little bit from your perspective on the mid-contract policy changes. I'd also be interested to know what is the language or what is the practice in other states as it relates to the mid-contract changes, as well as what some of the reasons might be at times to go with some mid-contract policy changes.
Yeah, thank you for the question. I guess to address them not necessarily in order, this is extremely standard contract language. It's standard within every contract we have at Anthem, both in Maine and in every other state. It's also standard in any contract that I was a part of in previous roles at other healthcare organizations. So this is just a fundamental part of what carriers have in their contracts to be able to ensure that providers are billing properly. And so, you know, as I mentioned, we try to ensure that we are communicating properly. The contract very much supports it. We did not do anything outside of the contract. I think that's probably important to note. Hopefully that's implied. So if there's any suggestion on Maine Health's part that we've done these outside of the contract, I think it's important to say that that would be untrue. I don't think I'm hearing that. I think I'm hearing that they just don't like them. And again, we view it as essential, not a nice to have, but critical. It's particularly critical in the environment in which we pay Maine Health. We pay Maine Health largely and historically always on a discount off of charge methodology. So they have a charge. We referred to the charge master earlier, and we negotiate a discount, and that is how we reimburse them. And it is extremely hard, very complex to ensure that they are actually paying us consistently with the contract. There's many ways that can not be the case. So it's essential that we have ways to ensure that we are being billed properly and that we have policies that ensure that we are being billed properly and that our customers are being billed properly. You know, as we think about ways to work collaboratively with Maine Health, because we know that they don't like these policies, but we know that they're required or essential, particularly in the way that we pay them today. The goal should be getting to a different payment policy. And Andy and I have talked about this in our one-on-one conversations, and he's alluded to wanting to get to a more current form of payment, which would involve things like risk and managing our patients in a way that ensures high quality outcomes at an affordable price. And so if we're able to get there, many of these policies actually become much less important because the way that we're compensating that doesn't require this type of thing, because they have much more incentive to deliver high quality, high value care. So I guess that's a long-winded answer. Chris, you may have something to add, but these are so critical for our customers to have to ensure that we are getting properly billed and that there is not overbilling and overcharges. But it is not something that we either like to do. It requires a lot of manpower to ensure that this is happening properly. And there is a path forward if we can get back to the table and be more collaborative in terms of what this partnership and relationship looks like on a go-forward basis. Those conversations began, but they stopped when we received the termination notice.
Thanks. And Representative Morrissey, the only thing that I would add is we do provide 90 days notice of any policy change. And typically our practice with Maine Health was to meet with them and discuss. They did mention that they provided some objection letters. We would meet with them to discuss those, but unfortunately, after we implemented the offset, they refused to meet with us. So we did not have the opportunity to discuss that with them.
Could I also just add one comment? I think I don't want to confuse issues, but when claims are denied for any number of reasons, the provider always has the ability to appeal. I feel like Andy Mueller had maybe suggested earlier that in his example of the denied claim of the 2 services that he had no option to appeal. That is untrue. Absolutely every claim can be appealed, and we do overturn many claims for a variety of reasons. We didn't have all the clinical notes. There was something missing from the bill. There was something unknown to us. So number one, every claim can be appealed. Number two, it's important that Maine Health has refused to include dispute resolution language in our contract with them. This is standard language we have with providers to provide a clear path for dispute resolution with us, and ultimately up to and including arbitration. And that helps us have a path forward to resolving issues together. Maine Health has refused to include that language in our contract, so we don't have clear, explicit language on how to resolve significant issues like some of the things that Andy has brought forward.
Representative Connor, go ahead.
Thank you, Madam Chair. In reference to Representative Morris's question, we've heard from Maine Health that there have been hundreds, I think was the correct term used, of mid-contract policy changes. My question is that all one way? Are you guys the only one making the policy changes mid-contract, or does Maine Health make changes as well mid-contract?
Maine Health makes changes routinely and often and without notice.
And is proposing to do so now with, they are seeking to reopen the existing contract.
But I would say even that would be at least a more transparent formal notification in the form of a termination letter. They make changes without notifying us that are contrary to our contract all the time. And I think Midcoast would be one example of the charging, and there are many other examples as well that we're not even formally notified of.
Representative Evans, go ahead.
Thank you, Madam Chair. Ms. McDonough, can you expand on the term that I've been hearing about algorithmic down coding?
Yes, it has to do with when a provider bill comes in that is inclusive of, say, additional charges or sort of upcode of charges or additional modifiers or different ways to increase the claim and therefore the reimbursement for a particular claim. So there are examples of when providers are submitting claims for things that we feel are either duplicative or unnecessary. And the edit is meant to review that and determine if that additional amount of money or that additional code or modifier that has been included is in fact appropriate for the services that were rendered.
And Representative Evans, you may recall that we talked a little bit about that during the session, and we have suspended that program in Maine. It was suspended last September and has not yet been reinstituted.
Okay, thank you, because I take strong issue with the term unnecessary. If I request, if I see a patient, evaluate that patient, make a decision that they may or may not need a certain procedure or whatever, I'm making a medical decision, and in my medical opinion, that's a necessary procedure. I think myself and most physicians or other providers would take issue with the description of that being unnecessary and that determination being made on the other end by someone who has not seen or evaluated that patient.
I think that's a fair comment for sure. I think I would also say that I don't think that we are suggesting that physicians across the board are doing things that we don't think are appropriate. That's by no means the suggestion here. I think it is absolutely a minority of situations where we think that we have concerns and issues. And, you know, we do, the folks that are evaluating and considering these programs are indeed clinicians. These are not being made by you know, non-clinicians. And they're looking at claims, and they're looking at previous behaviors and previous, you know, patterns. So this is not a you know, application to all, but I think it is fair to say that, you know, not every physician is alike. And there are some examples of when, you know, bills are submitted when I think you would agree, and perhaps we could talk offline with some examples that they are perhaps inappropriate.
Thank you.
Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you, Ms. Ossenfort and Ms. McDonough. I would like to follow up on the algorithmic downcoding question a little bit. Ms. Ossenfort, my memory was that you assured us that algorithmic downcoding was ceased for mental health care in Maine, not for all health care. Can you clarify that and
Sure.
and talk about that a little bit? And then I think we will have some discussion later from other providers who have indicated to us a consistent pattern of algorithmic downcoding, particularly DOs. And I'd like to hear more about that. So thank you.
Sure. So the evaluation and management leveling program is the program that we talked about previously. That has been suspended in its entirety for Maine and has been since September. I think what you're recalling, Representative, is that if and when the program is reinstituted or re-implemented, behavioral health will be excluded going forward. So they will be out of it. But at this time, the program has not been reinitiated for any type of provider.
Thank you.
Representative Melrano, I saw your hand go up briefly. Do you have a question? Go ahead.
Yes, thank you, Madam Chair. There has been a lot of talk about Maine Health today as maybe being the only provider affected by issues at Anthem, but there have been other smaller providers that have come forward and reported that they have had problems with Anthem, but of course they have less leverage certainly than Maine Health does. And it does sound like from what Ms. Ossenfort and Ms. McDonough say that they are working very closely and very collaboratively now with Maine Health and at the table. But are you also working that way with the smaller providers? And can you talk a little bit about that? Thank
Sure.
you.
Happy to. Thanks for the question. We're working extremely closely with the smaller practices. I mean, I think those are, you know, to my earlier comments, those are the folks that really have been most harmed by the delays in claims payment because they're not paid in advance of services being rendered. So we have absolutely worked hard to not only get our claims back, as I mentioned earlier, to regular turnaround times, but to meet with these providers, and if there's any historic claims that they feel have still not been paid, or there's denials that they wish to appeal, or any other issues that are occurring, to work with them on a case-by-case, one-on-one, or associations. We've met with the Association for Social Workers, and many of the, communicated directly with the physical therapists and speech therapists, and a lot of behavioral health organizations met with individually as practices and also as associations. So we are working really closely with these practices on a daily basis. We have a team of people in Maine who are responsible for the day-to-day with these folks. So they are in constant communication with them to hear any issues that still remain. And as I mentioned, I and others and Chris are meeting with some of the larger practices and the associations that represent those practices as well. And Chris, you may want to add to that as well.
I would just add that as Ms. McDonough mentioned earlier, we did establish a dedicated call line so that providers that are experiencing issues can reach out to us and get assistance. And I'd be happy to share that number with the committee when we submit our written testimony. I'll provide it to your analyst and she can share it with the members.
Okay, I have a couple of questions as well. One is goes back to a question I asked Maine Health, but they didn't really remember or have recollection of, but I know that Ms. Ossenfort and I had discussed at one point, probably in 2019, discussions around looking at reference-based pricing models to get away from some of these charge master disputes.
Yeah.
And looking at a Medicare plus kind of contracting model instead of using charge masters. I thought that I learned at that time that there were some contracts in Maine, or there was a contract in Maine that Anthem had successfully negotiated on that basis, but it's too deep in the memory of my pandemic-addled brain to be able to remember the details. So I'm hoping that you might be able to refresh my recollection.
Yeah, happy to. You're absolutely right. Your memory is completely correct. We did talk about that, and I am a little confused by Al's comments from earlier, but I will answer your question in the way that I think makes sense. We did move, Anthem and Maine Health did move to a version of what we call fixed payment pricing on, I believe it was 4/1 of last year, 2021. And that was for inpatient services. We call that DRG. It's just our version in internal Anthem. It's basically a Medicare-like model of paying a fixed price for services on a sort of percentage of Medicare-like approach. That did occur. We have, and they were the last system in the state to move to that. We've got our other large systems already on that payment mechanism. And our contract currently agreed to move them over to the fixed pricing methodology for outpatient services this past October of 2021. But they failed to do that, citing other priorities, starting with COVID, and then other reasons, Anthem related, that they failed to honor that commitment. So we sit partially on a fixed pricing methodology with them now, but not for the outpatient services that I referenced. That shift has not occurred yet. Chris, anything to add to that?
No, thank you. No, sorry, I had trouble finding the mute button. No, as Denise mentioned, we have 3 systems on that. Maine Health was supposed to move, I believe, and Denise can correct me if I remember incorrectly. They asked to delay it because of COVID, which we agreed to. A new date was set, and it still hasn't occurred as of yet.
Okay. So was this move to DRG based pricing part of the contract that was signed in January of 2021?
Yes, it was the contract that began on January 2021 with the agreement at on certain dates to move to these Medicare-like arrangements. Yes.
Okay, understood. So the reduction, the 4.25% reduction that we heard about earlier is based on a dispute over Charge Master 2, as you described it.
Right.
And so are those all reductions based on overcharges that occurred between 2016 and 2020 or
Yes.
2021?
Yes.
Okay, so they're historic overcharges that have now been corrected on a forward going basis by DRG payments?
No, sorry. The DRG, the shift to DRG did not correct or address the Charge Master 2 overcharges. They are distinct. That was still in discussion. We were in the Charge Master 1 discussion, which was resolved in 2020. And then shortly thereafter, the Charge Master 2 discussions ensued. But the contract that you're referring to did not account for in any way the overcharges that we described earlier in Charge Master 2, because we couldn't get to agreement on those for the contract that you're referencing. So those were ongoing discussions over the course of a couple of years, because we couldn't get agreement by both parties, and we were seeking the data to support or prove wrong our findings.
Okay, I think I understand what you just said, but I want to rephrase it and make sure I'm framing it correctly. Because this is very different than the way Maine Health presented it. Is it the case then that the Charge Master from 2016 that then gets these incremental increases, and you say those increases were inappropriately applied in 2017 to certain Charge Master 2 disputed items? I'm trying to understand what the current basis for services that are going to be provided tomorrow, let's say, are those still being charged to you based on a Charge Master that you believe is overinflated from 2017? Or are they being charged to you on a basis of something like this fixed payment pricing that has now gone into effect? Or is it a blend of both?
I'm not sure I fully understood the question, but let me try to answer it and then see if I answered your question. The current 4.2 offset that was mentioned earlier, that's Charge Master 2, that was put into place last September because it hadn't been contemplated or put into the contract in place right now. And that was done to correct overcharging on a go forward basis. Because had we not done that, these overcharges would persist on a go forward basis. What they didn't do is correct for the overcharges on a previous historic basis. And that's the roughly $55 million that was referenced earlier. Does that answer your question? I'm sorry if it doesn't.
It gets me closer because it's the opposite of what I thought it did. So that's helpful. But what I'm trying to do is reconcile that on the forward going basis with this idea that actually in 2021, the payment version or the payment approach that Anthem and Maine Health have negotiated, at least for inpatient services, is no longer based on a Charge Master from 2017. So there's some disconnect that I'm missing here, where it seems to me that the basis for the payments is no longer a Charge Master basis. So I don't understand why there would continue to be a problem that needed to be corrected on a full go forward basis. That's the thing I'm struggling with, because it strikes me that reference pricing is the correct way out of this problem, but I don't understand how you can then also take an offset on a forward going basis against the reference prices.
So Senator, I think it's because the base on which the DRG was determined was inflated by the overcharges. The DRG is too high because of the changes that were made to the charge master in the prior years.
So the
So the
basis for
DR
the the basis for the DRG included the 4.2% overcharges. So it was inflated.
The basis of the DRG is the old charge master. It's not some sort of outside of main health reference price like Medicare. That's the disconnect for me. I understood Medicare to be the basis for the DRG, or some other kind of Medicare-like type charge master that's not related to main health specifically, but is more of a reference-based pricing approach.
It's just similar. It's a methodology that mirrors Medicare, but it is not based on. But it is based. You have to get to a baseline of some sort in order to implement it, and the baseline was main health specific.
Okay.
It was based on historical payments. Well, they were taken into account in setting the DRG rate.
It's just a more predictable way of payment, as opposed to these discount off of charges that have lots of opportunity for shifting of dollars in between services, that make it very hard for us to audit, particularly hard when main health won't share the charge masters with us. It's just an extremely complicated way of ensuring that the services are being delivered at the agreed upon rates. So if we shift to fixed pricing, even though the baseline is meant to be specific to main health and might be different for other systems based on their specific utilization, it's a more predictable way and an easier way to ensure that the contract is being adhered to when you shift over to this Medicare-like fixed pricing methodology.
Okay. Representative Tepler, go ahead.
Thank you, Madam Chair. And I'm going to follow up on some of your questions, Madam Chair, if that's all right, Ms. McDonough. So when you signed a contract with DRG-based prices included for inpatient care, you had not yet completed the audit on the 2016 to 2020 costs that eventually led to your concerns about Charge Master 2?
Correct, because we could not get the data to substantiate or prove false. We suspected strongly that we were correct. We knew that we were correct in Charge Master 1. Main Health agreed to that, but we were still in dialogue around the exchange of data. And so we weren't able to include that in the negotiation or in the ultimate contract numbers when we did so in 2020 for 2021. It was still an ongoing discussion or point of dispute.
It's interesting to me then that you chose to use the Main Health Charge Master prices as the reference, given that you hadn't yet made that audit, instead of some sort of Medicare plus arrangement. So I'm a little confused about how this contract went forward without the audit, and with an agreement to do DRG, but without having really settled on a reference-based price.
Well, I agree, but we were at the term of a contract and we didn't want the same type of disruption that we're facing now. And so we had agreement on many important things, right? We had agreement to move to DRG. We had agreement, and these took months and months and months of discussions because there were certain things that, both parties, I assume, weren't comfortable with. This was just simply not something that was able to be quickly resolved. And it was identified as something that was going to require more discussion. To your point, it's not common to take, Medicare and just apply that as the baseline, nor would we even agree that that's appropriate. And I think others in the room would as well. It's the type of methodology that we're replicating. But, importantly, Maine Health would not even entertain this discussion about moving to DRG unless we included sort of every claim in the bucket that existed for Maine Health. So they considered sort of a revenue neutral kind of shift, if you will. We never agreed to that. We reluctantly even did this because there were things in there that we frankly didn't agree should be. This 4.2 and the dollars associated with it was not something that we were able to get agreement on. So to your point, we had to move forward with what the parties ultimately agreed to, with the shift to DRG, with Maine Health's sort of claims basis, with the knowledge that we were going to still have to work through this charge master 2 and take appropriate action when and if it was resolved.
Thank you. I guess I just want to say that it's my understanding that there are a number of other states that have passed laws about DRG or are working on laws about DRG type arrangements that are Medicare plus price-based. So 165% of Medicare or some such, depending on costs in the region. Thank you.
Representative Evans, go ahead. I think you get the last question.
Thank you, Madam Chair. So this should be quick. This is for either Ms. McDonough or Ms. Hcifs. Have either of you had any conversations with the Maine Bureau of Insurance about this entire process or issue?
Yes, we are in
both have.
constant dialogue with them. And Chris is the one who generally has that dialogue. So I'll turn it over to Chris. But yeah, we speak with the Maine Superintendent's office on a multiple-time weekly basis.
Yes, Representative, we have been in discussions both with former Superintendent Chapa and Acting Superintendent.
Thank you.
Okay. And just to put some context to the previous comment, I mean, you're absolutely right. There are states that do have those types of regulations. We of course are not one of them. And I mean, to put things into context, we pay well over 165% of Medicare. So we would like to get ourselves in a situation where we have much more predictable and what we would feel is appropriate pricing in a state like Maine, who faces some pretty significant affordability issues.
Okay, Representative Matheson, I see your hand up. I'm anxious to wrap us up for a break. Do you have a quick question that you want to get in before we take a break?
Yeah, thanks. Just real quickly, if you could include in some of the information what well above 165 is, I'd really appreciate that for Maine's costs. Thank you.
Okay. All right. Thank you, Ms. McDonough and Ms. Hcifs for joining. I know this is a little bit like some sort of examination at a doctor's office that you might not want to go to. So appreciate that. I think the committee's been sitting for 2.5 hours now. It makes sense for us to take, I don't know, do you think 15-minute break is adequate, Representative Tepler? Does that give you folks that are in person time to do what you need to do?
I believe that I had some nods from the committee. Yes, I have nods from the committee. So yes, I think we're comfortable with a 15-minute break for people to grab a quick snack and use the restroom.
Okay, great. I'm going to send Ms. Hcifs and Ms. McDonough back and thank them for their input today. And then we'll hear from the Bureau and the State Employee Plan after we take a 15-minute break. We'll be back at 12:45. Thanks, everyone.
Thank you all for your time.
And please turn off your videos while we're on break. to help with the YouTube situation. Thanks. Colleen, you've got a hot mic in the room.
Oh, it's mine?
Hey, folks, it is 12:45. Let me know how the committee room looks. It looks pretty empty, Colleen.
They should be coming back shortly, but you know, it's legislative time maybe, but they're coming in now. Yeah.
We were just discussing this past week that legislative time and Zoom time aren't the same.
No, they haven't been, but maybe when you get to a hybrid meeting that it becomes that way. There's a few, they're coming back now. So
Great, thank you.
Josh is here, Heather. He's just not on yet. And Heidi, I think, is still grabbing something to eat or using, yeah, I don't know.
Well, why don't we bring the folks from the Bureau across and then we can use our time wisely here. I'm going to bring in acting Superintendent Schott and Ms. Rawlings Secunda and Mr. Yardley. They should be on their way through the wormhole now.
Is Mr. Schott the acting superintendent?
Yes.
Thank you.
Okay, I think we have everyone. I guess first we should start by saying welcome to Mr. Schott. I don't think our committee has met you before, and you have big shoes to fill, as I'm sure you know. But we look forward to hearing from you today and working with you in the future for sure. Okay, I think we've got everybody now. So I will just turn it over to the three of you from the Bureau. I did provide Colleen with sort of an outline of a few items that I'd like to have you guys go over, and then we can ask questions from there. So please begin your briefing.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. Can you hear me okay? Hopefully, okay, great. My name is Tim Schott. I'm the Deputy Superintendent as my day job, and I'm currently also working as the Acting Superintendent, as you mentioned. I don't believe I had a chance to talk to you all this session. Just so, I guess, quickly about my background, I have been a Deputy Superintendent at the Bureau for 13 years. And prior to that, I was a prosecutor in the state of Iowa for 14 years. And you all know Ben Yardley, of course, and Joanne Rawlings Secunda. Glad to talk to you today. You know, we've obviously been concentrating on what our legal authority here is. Some of that has already been mentioned by the previous guests, but just a couple of things I guess I'll bring up. The first is, of course, emergency services. I think it's been mentioned, assuming Maine Medical Center goes out of the network, emergency services still need to be covered. That's an existing law, whether providers in network or not, so that shouldn't be affected. There's obviously any insurance carrier has to have an adequate network. So if Maine Medical Center were not in Anthem's network, Anthem would still have to demonstrate to us that they have an adequate network for any services that Maine Medical Center would otherwise provide. So of course we will be concentrating and focusing on that. A couple of other provisions. One is that there's under the Health Plan Improvement Act, there is a right for continuity of care. That's basically a minimum of 60 days after the termination of the contract. And that can be a longer period if the provider and the insurer agree. So that's also a legal provision that's out there. In addition to that, I guess I should mention the Rule 850, as well as the Health Plan Improvement Act, requires as part of an adequate network that if for some reason there's a provider that's not in the network and that service needs to be still included by the plan, the insurer has to make that available to the consumer. So that could be, by agreement between the provider and the insurer, or otherwise. But if the network is not adequate, that doesn't mean that the service isn't going to be provided. So that's kind of some of the legal authority that we're working from. I think it's been mentioned that we have talked to Anthem. We have talked to Maine Health also. We've encouraged both of them to do their best to work this out. The legal requirement as far as notice for Anthem to let its consumers know about a termination is 60 days. So actually that would be November that Anthem would have to notify its members if an agreement is not reached by then. But of course, 60 days is cutting it close for people to know what's happening. So we would expect Anthem to have contingencies in place prior to obviously that time period. So those are some of the areas that we're focusing on at the moment.
Okay, can you speak to the payment provisions that I asked a little bit about when we were questioning Maine Health? Are there differences between different types of services in terms of what the reimbursement would be for out-of-network coverage that has to be covered for the various reasons that you mentioned?
Yeah, I'll let Joanne address that, but I believe the statute doesn't really say as far as the provider what they're going to get paid. The focus of the statute is to make sure the consumer is held as if it was in network for their cost sharing, but Joanne may want to add to that.
Yeah, I think that there are two pieces here that we're kind of discussing. One is if this is a covered benefit and no one else can provide it. And then yes, 100% the consumer has to be held harmless, which means if they had a copay before, it's a copay. If they had, coinsurance, it's coinsurance, but it's the same way, same amount of coinsurance as if it was an in-network provider. The other piece here is continuity of care. And, as Acting Superintendent Schott mentioned, the carrier has to provide 60 days notice, assuming they get at least 60 days notice from the provider. They have to provide 60 days notice to any of their enrollees that are using that provider for care. And that once the contract is terminated, they can have, well, let me back up. Let me say this right. From the time that notice goes out, they can have the enrollee can definitely get at least 60 days of continued care. Or if the enrollee is in their second trimester, excuse me, of pregnancy at the time of termination, then it is covered until through postpartum care. The thing in that situation, the other piece of the law here says that basically that the carrier and the provider have to agree to terms. So the carrier can make it conditional based on that, for example, that the provider accept the terms that were in their existing contract before the termination. And the carrier also can make this conditional on that the provider adhere to any of their quality of care standards that were in place before the termination, and any other policies and procedures, like, for example, referrals, prior auths, that kind of stuff. So it's basically, it kind of freezes everything in place. So when you're talking about the former part, when you're talking about that there's a specific service that no other in-network provider can do, then Acting Superintendent Schott is correct that there is nothing specific in the law about how the payment goes. When you're talking about continuity, there are some things set up in the law for that.
And isn't there a third piece as well with regard to emergency services? And there's maybe baseball arbitration there?
Thank you. Yes.
Baseball arbitration there?
Well, there is baseball arbitration there. That's that is an option. But the first piece of that, I go back to that the consumer is held harmless. So the consumer is held as if this was in network. Then if the carrier and the provider are at odds about how much should be paid, that's when we go into the step of baseball arbitration.
And I think baseball arbitration would only apply in emergency situations, and maybe if they're providers, the anesthesiologists or something like that, we're out of network, but the site of care is in network. Don't we have a specific?
We do have we do have a specific no surprises about providers out of network when the consumer expects them to be in network. Once again, it is the consumer is held to the same standards if it was in network. The baseball arbitration, our independent dispute resolution process that we're working with Maximus as the entity, that really is limited to emergency. And if I'm wrong on this, I'm hoping my staff will tell me right now.
Mm-hmm. No, I think you might be right. We went around in circles and I couldn't remember where we landed, but I don't think that's going to be the circumstance here anyway. If MMC were to pull out, it wouldn't be a circumstance with like Spectrum physicians providing service out of network, as we've seen in the past. Representative Tepler.
Thank you, Madam Chair. I was wondering if we have anything in Bureau of Insurance rules or law regarding dispute resolutions in provider and network and insurer contracts. And if we do not, would it be reasonable to think about requiring all contracts to include some form of dispute resolution?
So I don't believe there's anything in the statute as far as that between the provider and the insurer currently that has to be in a contract. If you're just asking my opinion, I think something like arbitration, I think it is in a lot of contracts, and as I think you're suggesting, that's that's an avenue that can help potentially resolve some of these types of issues, I would think. But that might be better, for the parties involved in this contract to answer.
Thank you. I guess my understanding at this point, Acting Superintendent, is that at least one of the parties did not wish to include that in a contract. And that concerns me greatly. So thank you.
Okay. So what does the, I guess the other thing we haven't talked about much at all today is the market conduct examination that is being undertaken with regard to Anthem. So I guess I'll just leave that as an open-ended question. If you folks could share, whoever's most appropriate could share what prompted that, what the status of it is, what the timeline of it is, and what it entails.
Yeah, I can try to answer that. So market conduct examinations are confidential, which you're probably aware of. So I can't get into a lot of details, but I can tell you some general things, including that under 221.5 of the insurance code, there's a requirement every 5 years that we examine health insurers. So actually that exam was on the schedule because of that statute. So once we do an exam, of course, we can include whatever issues we think are important to look at. And as the exam goes along, issues can also be added if appropriate. So the just again, in high level terms, the exam is focused on several areas, including mental health parity, provider relations and contracting issues, and compliance with Rule 850, which a lot of that has to do with appeal rights and other types of notices that the insurer must give to consumers. So those are the areas of focus of the exam. The exam is in process. These things take quite a while. Just speaking generally, an exam includes obviously analysis of a lot of data, a lot of claim files, a lot of other information. There's a lot of back and forth between the examiners and the company being examined as far as objections and agreement to objections and more information being requested. So there's a lot of back and forth that happens. What is actually a public record is kind of at the end of the process. When there's a final report issued, the report is a public record. So, so we're still several months at least away from that happening. As far as it being completed, it is pretty comprehensive and it's addressing a lot of areas. So I hope that helps.
Okay, so can you give us a sense of the, like, from beginning, obviously not for the Anthem case in particular, but from beginning to end of a market conduct examination, how long would you expect that span to be?
So it depends obviously on how complex it is, how many different issues you're looking at. A year and a half is not unusual at all. We've had some that have gone beyond 2 years. So it's a lengthy process. One thing that's important to point out though is that it's not just an exam starts and nothing happens until it's over with. As the exam is in place, if errors are found, corrections are being made as the exam goes along. So things are pointed out to the insurance company if there is something not being done correctly, that they should correct it. So oftentimes when you get towards the end of an exam, actually many of the errors that were found should be fixed by that point, by the time the final report is done. So I just want to make sure you understand that it's not like nothing is improved or corrected as the exam process goes forward.
Okay, and is there, I understand the end process is a report, which is a public record. are there also penalties or disciplinary actions that are taken if violations of Rule 850 or violations of other provisions of our statute have been found?
So that is definitely a possibility. If you look on our webpage, we have prior consent agreements and exam reports that are listed there. So what the superintendent would do when the report is finalized is there's a variety of things that could happen, including a corrective action plan if there are violations, where the insurance company would be required to have a plan on how they're going to correct things that have not been corrected up to that date. There can be penalties if it's appropriate. There can be restitution to consumers, for example, if there were overcharges that were found. So there's a variety of things that can happen that would usually happen at the completion of the process, obviously. It's also something that if there's violations found, the typical way it works is that we attempt to reach a consent agreement with the insurance company on what we believe are the appropriate penalties and corrective action. If the insurance company disagrees with that, they have a right to a hearing. There's a due process right, of course, to a contested hearing where those types of issues would be decided.
Representative Evans, go ahead.
Thank you, Madam Chair. Mr. Shaw, thank you for being here with us. Just thinking back, when this issue first surfaced several months back between Anthem and Maine Health, I had spoken with Superintendent Chopper at that time because I was getting calls about the algorithmic downloading. He indicated to me at the time that his office was also getting several concerns or complaints about that as well, and that his office was going to begin an investigation. I guess my question is, do you or anyone else have any input as to where that investigation stands, or if it exists today?
So, yeah, I don't know if Eric would have been referring to market conduct exam or something separate. Investigations are confidential, just like an exam is confidential. But I guess separate from that, I can tell you that our staff have been working with providers on those types of issues since probably last summer is when we started getting a lot of them in. We've been encouraging Anthem, obviously, to address these as quickly as they can. This is something Joanne might be able to speak to a little bit more, but on kind of a separate track from investigations, market conduct is the stuff that we do every day. As far as, we find something that, appears that it needs to be corrected. We talk to the insurance company and encourage them strongly to correct the situation. And Joanne, did you want to add anything about that?
I just want to add very briefly, yeah, we started having weekly meetings with Anthem basically the end of August or early September about a number of provider issues. And that the downcoding came up in those discussions. But we were working with Anthem to make sure that all of the provider issues that we were seeing were being dealt with. And as Ms. Hcifs mentioned a little earlier, they paused the E&M program, the downcoding, at least for the time being, until they can re-examine it and go from there. So that's the piece of it that we have been involved with at the Bureau.
Thank you.
For additional questions for the Bureau, I have more if no one else raises their hands, unsurprisingly. Okay. So my other sort of set of questions is about this sort of assertion that the providers are not regulated and the insurers are regulated. Obviously, the insurers are within your purview, but I'm curious to know from your perspective whether you have enough ability as we look at this out of network piece coming forward to be able to ensure that providers and insurers are sort of on a level playing field in terms of being able to negotiate for appropriate payment. It seems to be an issue with regard to our EMS providers. We got an update about that yesterday, where the insurers hold all the cards because of the way that we wrote the law. And then it seems to be an issue here on the other side, where it would appear to me that if MMC goes out of network, they could extract very high rates, full charge master rates for any services that they uniquely provide in the state of Maine. So I'm hoping you could speak to that. And I realize it's a bit of a policy question, which you may be a little shy to answer, but I'm trying to figure out how we get those folks on equal footing in terms of their negotiations.
So yeah, I am trying to think through how to answer that. As far as the Anthem Maine Medical Center issue, I don't believe the statute that we've referred to, as Joanne mentioned, says there's a particular payment method. You know, it's if the network's not adequate and there's this missing service, I think the statute basically says it just says the insurance company has to provide it, has to make it available.
Yeah.
So I think there aren't statutory limits on what that could be. You know, my hope would obviously be that at least to that extent, the parties could reach some understanding or agreement that for the next 6 months, this is what we're going to do, this is what we're going to charge as we continue to dispute the other parts of the contract. Does that answer your question, I hope?
Right, but there wouldn't be any ability of the Bureau to tell Maine Health or MMC that they're charging too much for these out-of-network mandatory services.
Yeah, as you mentioned, we don't regulate those entities, so I don't think we would have any authority to make them charge a certain amount.
Okay, except in the cases that are covered by the No Surprises Act or by our own baseball arbitration.
Yeah. As far as the consumer, as we've mentioned, they should be held harmless. It's the insurance company that may not have the limits on what can be charged.
Okay. Which ultimately impacts consumers in the form of premiums the following year.
Yeah, I think that's true. Yep.
Okay. Are there additional questions for our Bureau? All right, not seeing any. Oh, Representative Tepler has her physical hand up. She's challenging my concentration here. Go ahead.
Thank you, Madam Chair. And thank you very much for being here, both Mr. Schott, Acting Superintendent Schott, Mr. Yardley, Ms. Rawlings Secunda. As a member of this committee, I'm frustrated with the he said, she said it, as it were, of what seems to be going on here. And I am worried about Maine consumers and how we can keep working to keep their costs down so that they can have affordable health care with this kind of ongoing situations. I am wondering what kinds of things we can think about as a committee that would be helpful, and whether you have any suggestions to this committee for actions. And as far as I'm concerned, that can come in writing. It doesn't have to be right this second. but I feel frustrated at not being able to protect consumers in this environment.
I was trying to find my unmute button here. I don't know if Ben or Joanne have any thoughts on that. That may be something we want to get back to you on, but the constraint we have, of course, is as been mentioned, we regulate one side of it, so so that's kind of all we can focus on, in addition to encouraging both sides to try to come together and reach some agreement. That's probably not answer your question, but that's what I have, unless Joanne or Ben have something else to add.
So I guess the follow-up question for that statement would be, does anyone regulate medical providers other than their own professional organizations?
Oh, I can't give you an absolute definitive answer, but I can say that I talked to the Maine Purchasers Alliance asking that question, and they didn't know of any state that had, or there was a state agency that had jurisdiction over provider pricing. So, I mean, we can keep looking for that, but as of this moment, we don't know of any.
And
thank you.
Representative Arford, go ahead.
Yes, thank you, Madam Chair. Just a quick question to follow up on the letter that a constituent had shared with me that had come to them from Maine Health, explaining the situation with them withdrawing from the Anthem network next year. There was a statement in it that said last week, the Georgia Office of Insurance and Fire Safety, and this letter is dated April 7th. Fire Safety fined Anthem $5 million for practices similar to what Maine Health has experienced. Are you familiar with this action? And can you tell us anything more about it?
Yeah, we have read it. Some I can tell you some information about it. It's the time period. Backing up for a second, it was based off of a market conduct examination that was done in Georgia. The time period that they were examining is largely, I think, earlier than the current situation we're discussing. It was like 2015 to 2021, with most of the violations being between 2015 and 2018, I think. But at the end of that examination, there was a $5 million penalty imposed, as well as a corrective action that Anthem needs to comply with. So yes, we have seen that.
Thank you.
I muted myself. Okay, Representative Melron, you go ahead.
Thank you, Madam Chair. Yeah, my question would be, because this is a really, Maine Health has sort of taken somewhat of a sledgehammer to this problem, sort of announcing, in my mind, sort of announcing and creating this instability among their patients. My question would be, were there a lot of complaints lodged to your office about Anthem by Maine Health before it came to this point? Thank you.
I think Joanne was about to answer that.
Yeah, I didn't want to step on any toes.
Yeah. Go ahead, Joanne, sorry.
Quick answer is no. I mean, we have met with Maine Health several times, but in terms of us getting consumer complaints related to the Maine Health situation, no, we haven't gotten any consumer complaints. We got a bunch of consumer phone calls and inquiries after it went public, but that's all we have seen so far. Does that answer your question?
Yes, thank you.
Ms. Rowling-Secunda, I know that there's a consumer health care assistance kind of function of the Bureau of Insurance. Is there a provider assistance function of the Bureau of Insurance, or is that outside the scope of your operations?
Officially, it's outside the scope of our operations. We are, as you mentioned, the Consumer Healthcare Division. That was the statute that created the division was very clear that that's what we're supposed to do. So when it comes to taking written complaints, for example, most of our complaints are from consumers. But we occasionally take a complaint, very occasionally take a complaint from a provider if it does look like it could be a network adequacy issue. We've also, when we were having our weekly meetings with Anthem, we were bringing to them not complaints, that's not the right word, but issues that were brought to us by providers, very specific issues by very specific providers. So it's not that we never get involved, but it's technically not what we do.
Right. That's what I thought. And, we've talked a lot about credentialing in this committee and the delays that have been experienced in credentialing, which I think may have been somewhat resolved at this point. And we just passed a new statute with tighter timelines related to credentialing, but it remains a little bit unclear to me how the Bureau would enforce that, given that they don't really have a way for providers to be the ones complaining, but only for consumers to complain. And I'm not clear on whether a provider is supposed to find patients who they can't see and then have those patients complain about the lack of credentialing, which is certainly something I have done personally as a patient. But I'm a bit confused as to how we could streamline that type of enforcement and compliance on the part.
I mean, in those situations, I mean, where we clearly have a statute or a reg that that they're clearly supposed to be complying with at the carrier level, that's the kind of situation that we can get involved with providers. So, we're figuring with the change in the law, we're going to be doing changes in rule to 850, as you remember. We would be, if a provider came to us on that, we would definitely be investigating that.
Okay. And I assume that's also the sort of thing that can get folded into a market conduct examination. Are providers part of the investigation that goes on during market conduct examination, or is all of the information provided solely by Anthem to conduct, or by the insurer? I know you guys can't talk about specific cases, but is there, in most audit situations, you would be looking to get independent verification of the data that's being provided by the company that you're auditing. So is there a formal process by which providers who do business with a carrier are asked for their verification of data with regard to a market conduct examination? Do you understand the question I'm asking?
No, yeah, I think I understand.
Okay.
So there's not a process for them to kind of intervene in the examination. There are circumstances where we would have providers. One that comes to mind is in some mental health parity situations where the examiners don't have the expertise in a particular area. They may actually contract with a provider to come in and basically act as a consultant for them on that specific issue. So there's a lot of in an examination, there's a lot of different areas we can look at, including bringing in expertise like that if needed.
Okay. And just going back to the issue of no state having any sort of regulatory authority over pricing of providers, I think there are a couple of models for that in Maryland with hospital global payment type of model. And I think Rhode Island has some of that. And then of course, Massachusetts has at least targets for payment or for cost growth. So I think there are some models. Maryland's probably the closest to it. And I think Maryland's actually gone to an all provider model for global payments, not just hospitals. So it may be worth us circling back on that issue because it does seem like a gap. It just came to mind as after we had moved off the question. So I wanted to throw that back on the table for the committee. Okay, I don't see any other hands up for our bureau. So I'm going to thank you folks for joining us very much in this interim meeting. And I'm going to move you back into the attendee portion, and then we're going to hear from Ms. Trundy. Thank you. I have to remember to try and mute myself before I cough. Okay. Good afternoon, Ms. Trundy. Nice to see you.
Good afternoon.
So thank you for joining us. We certainly have heard a lot of information over the last couple of hours. We're interested in getting an update. We know we've heard from a lot of our constituents who are concerned about either their employer's plan or the state employee health plan, which is your area of responsibility. So I'm hoping you could give us an update as to the status of the state employee plan with regard to its third-party administrator being Anthem.
Yes, absolutely. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Healthcare, Insurance, and Financial Services. I'm Anya Trundy. I'm the Chief of Legislative Affairs and Strategic Operations for the Department of Administrative and Financial Services, or DAFS. And I'm here before you today on behalf of the State Employee Health Plan and the Office of Employee Health and Wellness. Although HCIFS is the committee of jurisdiction for both of those, we didn't have much occasion to come before you during the 130th. So I want to quickly ensure that everyone has the same baseline understanding of the State Employee Health Plan and the state's relationship with Anthem. The State Employee Health Plan is a self-insured plan, as you may know. In layman's terms, this means that the state does not pay insurance premiums to an actual insurer, such as Anthem, but instead sets aside its own pool of money and pays its own claims. And this is possible because we have a large pool of members across which we can spread the risk in the same way that an insurance company does. Benefits and overall design of the plan are set by the State Employee Health Commission, and the Office of Employee Health and Wellness currently contracts with Anthem as the plan's third-party administrator, or TPA. Among other things, this means that we've contracted with Anthem to process claims on behalf of the plan and to use Anthem's provider network, billing codes, and other infrastructure for the employee and medical-facing portions of our work. As you may be aware, state government is the second largest employer in Maine, and like every other employer, Maine Health's April 6th announcement that they were serving notice to Anthem and intended to remove Maine Medical Center from Anthem's network beginning January 1, 2023 is deeply concerning. This action would mean that Maine Medical Center was no longer considered in-network. For many state employees, Maine Medical Center may not be their local hospital, but Maine Medical Center is the largest tertiary care hospital in Maine. And as such, it may well be the hospital that they and their loved ones turn to when going through their most serious health struggles, when they require highly specialized medical care and access to the most advanced treatments in state-of-the-art facilities. Just as Governor Mills said in her April 6th statement, this termination should be avoided at all costs. Both parties should put the interests of the Maine people first and resolve this dispute in a timely way to avert such a drastic and damaging move. From just a cursory assessment of the potential impact on the 25,524 members of the State Employee Health Plan, should Maine Health follow through, we know based on easy to obtain, regularly reported top line metrics that Maine Medical Center is our largest provider of inpatient services. Over the last rolling 12-month period, Planned medical claims paid to all providers totaled over 175.5 million. Inpatient claims for facilities that it is our understanding would come under Maine Health's announcement totaled 9 million, and outpatient claims totaled an additional 11.4 million. This is a combined total of 20.4 million, or 11.6 of the plan, 11.6% of the plan's spend on medical claims. The actual impact should not be this broad, as these figures include services and providers that state laws and regulations would require Maine Health to accept in-network rates for. For example, we know if Maine Health were to take this step, that it would not apply to emergency services, and the continuity of care and network adequacy provisions would apply under certain circumstances. However, when you consider that 99% of all plan claims are in-network, such an action certainly would introduce a completely avoidable degree of complexity into our members accessing the healthcare that they need. Employee Health and Wellness continues to evaluate plan claim data to develop a more refined sense of the anticipated impact on plan members should Maine Health and Anthem not resolve their differences. Based upon what we know right now, if a network removal comes to pass in 2023, Employee Health and Wellness is prepared to mount a communications campaign to ensure that the 25,524 plan members are well informed of what these changes would mean for them, including clarity on which services will and won't be impacted, whether they've previously received services that may not be available in the same place or covered in the same amount, and where in-network alternatives may be accessed, especially for those plan members in Southern Maine, an area of the state that has the highest concentration of available providers and facilities. Employee Health and Wellness routinely communicates about benefit changes resulting from annual plan redesigns, passage of new laws, etc. Although the office does its best using various means of communication and reinforced messaging, healthcare can be confusing, and folks may not carefully examine their plan documents or read the myriad of mailers and email updates that we send. Ironically enough, though, it's quite possible that due to the high profile nature of this dispute, its stature might make the communications process easier rather than harder in this instance. Employee Health and Wellness is also prepared to provide increased assistance to ensure that plan members continue to access the health care they need with the least amount of personal disruption and out-of-pocket expense. An example of an available alternative, the State Employee Health Commission recently approved a pilot benefit made possible by the self-insured nature of our plan that through Carum Centers of Excellence will cover 100% of the cost of certain knee and hip surgeries. As I mentioned in the beginning of my remarks, the state contracts with a third-party administrator, which has been Anthem since July 1st, 2017. This contract is awarded through a competitive bid process, and Anthem has not always held this contract. Aetna was the most recent contracted TPA prior to 2017. Employee Health and Wellness is currently drafting the RFP with intention of going out to bid this fall for a new contract. Using our historic timeline for this process, we anticipate making an award in late 2022, executing the new PPA contract during the spring of 2023, thus ensuring the vendor being in place for the 23-24 plan year effective next July. The work and timeline of a major procurement such as this cannot be condensed. It provides adequate time at each stage of the process for careful due diligence and thoughtful consideration. Most importantly, should the procurement process result in a change in vendor, this timeline provides sufficient time to execute a smooth transition between TPAs and to prevent plan members from experiencing any interruption to the care they need. Given the alignment between the timeline communicated by Maine Health and the state going out to bid, this provides us an opportunity to weigh the concerns that have led to Maine Health serving notice to Anthem. Employee Health and Wellness meets regularly with Anthem to address issues as they arise. And the contract includes performance guarantees that employee health and wellness holds Anthem to. One performance guarantee of particular relevance to why we're here today requires Anthem to process 90% of claims within 14 days of receipt. We have actual figures on this performance relative to the performance guarantee based upon information provided to employee health and wellness at their weekly meetings. 98.19% of claims were processed within 14 days in 2019-2020, 93.53% in 2021, and through Q3 of the current 21-22 year, we're currently seeing 98.85% of claims being processed within 14 days of receipt. Further review of the aging reports also shows that there are currently 120 outstanding claims to Maine Health that are older than 14 days. They total approximately 485,000. Of these, 58 claims are less than 30 days old. And then more specifically to Maine Medical Center, there are 7 pending claims, and 6 of these claims are less than 30 days old. The RFP process can also take into consideration both positive and negative contract performance, not just specific to our current contract with Anthem, but also any publicly available information, including findings from the market conduct exam currently being conducted by the Bureau of Insurance if they were available at the time. In closing, I want to say that we believe that state employees and their families deserve high quality, affordable health care, and that it's the administration's plan to continue delivering it. It is our hope that these 2 private parties will reach a resolution. We will continue to closely monitor the situation and keep employees informed of any potential impacts to the state employee health plan, and we're mindful of the anxiety that this dispute unnecessarily causes our members. Thank you for inviting us to speak on the matter, and I am happy to respond to any questions from the committee now.
Thank you, Ms. Chundy. Are there questions from the committee with regard to the state employee health plan? So I have, go ahead, Representative Tepler.
Thank you, Madam Chair. I'm sorry, I forgot which button I was supposed to push there for a second. Appreciate the recognition. And thank you so much for being here, Ms. Trundy. From your statement, it was a little unclear to me about whether the new contracting process would include access to Maine Medical Center as an important piece of what should be in network. I mean, what should be available to state employees. Can you speak to that a little bit?
Yes. So currently in the contract with a TPA, part of what is contracted is for the use of their network. So our network in the future contract will be the network of whatever provider is selected as the new TPA.
And access to the largest tertiary hospital in the state would be considered in that contract.
Yes, there are ways that such things can be taken into account during the RFP process.
Thank you. Thank you very much.
I don't see any other hands from the committee, so I'll go ahead with some of my questions. Is there a provision in the TPA contract with Anthem that would allow you to go around them to contract separately with MMC?
I'll have to get back to you on that. I don't know the answer to the question. It is not something that has been suggested to us at this point in time. And certainly our ideal situation is to have this situation resolved, because it's certainly the most simple and in creating the least complications for us going forward. I think for us, we don't necessarily have that in-house expertise. You know, that's part of what we are relying upon Anthem as our TPA currently, or whoever the TPA is. That's what we're relying on them for, is that degree of negotiation with the medical providers over rates.
Yeah, the reason I bring it up is because Maine Health made a comment about wanting to work directly with employers, and yeah, it strikes me as a thing that employers may not be in a position to do.
I can get back to you on whether there is anything that is prohibiting it or not, but it's not an option that has been broached with us.
Okay. Yeah, I was surprised by that suggestion myself. Representative Matheson, go ahead.
Thank you, Madam Chair. When is this contract completed with Anthem? What's the time period of your contract with your GPA relationship with them?
So the period that we are about to enter an extension with them for a year while we are going through the RFP process to find our next TPA. That will complete on June 30th of 2023. And the new TPA will be in effect as of July 1 of 2023.
Thank you.
Has there been any discussion of a mid-year termination to match the leaving of MMC?
I have to say there was a little bit of discussion of it, but frankly, the timeline can't be met on our end. We just simply can't go through an RFP process between now and then, and also with the potential that we would have to bring on a new vendor and go through that whole administrative transition. Like, we just need a matter of months to complete that transition if that were to be the case.
Okay, understood. Representative Tepler, go ahead.
Thank you, Madam Chair, and thanks again, Ms. Trundy. My question is, should this dispute not resolve in time, would or does the current contract with Anthem allow you to notify the state employees who are covered under your plan of what hospitals are in network, both in state and out of state?
I wouldn't think that there is anything that would prohibit us from that communication. I think that is the type of communication that we would intend to offer our members. That just seems to be good communication and good service to them. I will verify to ensure that there's not anything within our current contract that would prohibit that.
Thank you. That would be helpful.
Yep.
Yeah, I mean, I think under our directory rules, it would be required that the directory be provided and up to date. Okay, I don't see any other hands up from the committee. We do appreciate the update, even as sort of equivocal as it is. Unfortunately, I think there's a lot, 23,000 or so people in limbo just in the state employee plan, wondering how this is going to play out. So thanks for being here. I'm going to suggest to the committee that we move Ms. Trundy back to the attendee space and thank her for her input. I'm going to do that.
Thank you very much.
Thanks. And then I'm going to suggest that we take just a quick 5-minute break and then turn to public comments. And before we do that, before we take the break, I'm going to ask anyone who's in the meeting who intends to speak during our public comment period to please raise your hands now, if you would, so I can just get a count of how many people we're going to hear from this afternoon. I'll give it a minute as the hands go up in the participant list. Raised hand is not working for one person. Okay. I see the rest of them hands raised though. We'll figure out why Mr. Moran's hand is not up, and we'll make sure he gets the chance to chat as well. So it looks like we have 10 attendees who are intending to give testimony. So if we can hold everybody to 3 to 4 minutes, including questions, that we'll be able to get through this in under an hour. But I just wanted to let the committee know how many people we had, so that you have a sense of what the timeline looks like for this afternoon. I know this is running longer than we had anticipated, but I guess maybe not surprisingly so, because it is a really important issue for Mainers. So I think it's worth the time that we're spending on it. So at this point, I am going to have the committee take a, let's call it a 14-minute break, and we'll come back right at 2. And then we'll go through the public comment period at that point. Thanks, everybody. I'll see you at 2. All right, I am here and hopefully some folks are in the committee room and ready to get started.
Everyone's coming back on, Heather.
Great, thank you. I appreciate all of the texts of support I've gotten. I'm okay. I just have a cold symptoms. I don't have a fever. And I'm just letting folks know that I'm writing down the names of the folks who have their hands up. And I'm just going to call on folks and bring them across in the order that they appear in my attendee list. I'm not really sure what order that is. Usually it's alphabetical by first name, but it does not appear to be at the moment. So I'm not really sure. It might be in the order you raised your hands in, which is a bit random, but that is where we're headed. If you are not available at the moment when I try to bring you over, I will circle back to you within the public comment period at the end and hope that you're available at that time, because I knew we do have some providers on the line. Okay, so with that, I will bring over Jeff Austin first. I think everybody's back enough that we can get started. Yeah, I see a few people in the room still with their cameras off, but I can't tell if they're there. It looks like Josh is there. Okay, great. I'm gonna go ahead and get started. So I'm bringing over Mr. Austin. And again, just a reminder that during this public comment period, we will be sticking to a 3-minute clock, which I will have on my phone. I'm going to put it up into the window of my screen here. When you have about 15 seconds left, I'm going to ask that you really try and stay to the 3-minute time frame, because it's been a long day and I have COVID. All right, so with that, Mr. Austin, please go ahead.
Thank you, Senator Sanborn. Sorry you have COVID. I will try to be very quickly. Thank you to the members of the committee. You have in writing from us the results of a survey we conducted of our members about 6 months ago regarding this issue. It had popped up to us as an increasingly big issue for our members, particularly the aspect of billing and collection. So we did a survey. You have those results. I'd ask you to look at them. They include not only numbers, such as of the end of last year, Anthem owed our members $350 million. Subset of that is 90 days or older was 120 million. 120 million more than 90 days old. But there's also some open-ended comments that I'll ask you to read, including ones like, Anthem used to be a quick and consistent payer, and they aren't anymore. There's always headaches and tension between payers and providers, but something has changed. This is not just Maine Med. You can see that from our survey results. It's not just hospitals. You can see that from the comments from chiropractors, therapists, doctors, and others that are in writing and in the record now for this hearing. And it appears it's not even just Maine, as you can see from the fines in Georgia and Indiana and elsewhere. Something is going on. Random fact that came across my desk. A lot of random facts came across my desk. You guys oversee the individual marketplace in Maine. Maine Anthem had the 3rd highest initial claim denial rate in the country. 40% of claims denied. 40% of initial claims denied. That system is broken. There's no way that's fraud on the provider's part. There's no way that's fraud on Anthem's part. They're just not paying legitimate claims. That's a system where we can't navigate it. We can't submit the claim in the way that it'll get paid. It's become easier to do the brain surgery than to collect payment for brain surgery. Why is this going on? Please remember what you already know. There is asymmetrical power in this relationship. If I buy a beer, I pay for it at the same time. If I get my car fixed, I don't get my car back until I pay for it. The service and the payment cross each other in real time. Asymmetric power is when the carrier gets the benefit of the bargain, medical treatment for their patients, but we have to spend 60, 90, 120 days chasing payment. It doesn't cross the table. Asymmetric power too was illustrated to you by Anthem, and that is they're not just a combatant when we have a dispute over billing. They should question our bills. We're human, we make mistakes. They're also the judge. They made that very clear. We asked Maine Med for information, and when they didn't provide it, we decided against them. In closing, all carrier provider relationships have this asymmetrical power. I think the straw that's breaking the camel's back is this new issue of taking old language from contracts about policy changes, unilateral policy changes, and they've weaponized it to the point where our guys are crying mercy. We cannot manage a system with that much asymmetrical power. So the only thing they have left is to say, maybe we can't play this game anymore. I have plenty of else I would like to say, but I understand it is a long day, and I want to respect your time. So with that, I'd wrap, and I'd be happy to take any questions.
Thank you, Mr. Austin. Are there any questions for Mr. Austin? I do appreciate the comments, and I'll just point out to the committee that the survey that Mr. Austin referenced, Colleen has it, but it hasn't come to the committee yet because it came in late this morning. So she'll get it out to us after she's done in the committee room. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you, Mr. Austin. I'm sorry we don't have your survey in front of us. I'd like you to review the information you provided about 40% of initial claims denied and where that comes from.
Sure. The federal government is requiring some data collection and reporting. I found it on the Kaiser Family Foundation website. I think it's available elsewhere. I can send the link to Colleen. To be clear, that's not 40% of claims ultimate denial status, but it's the initial claim gets denied. And so what happens? We spend a lot of administrative resources chasing it down. And then I come into the insurance committee and get yelled at about how expensive administrative costs are with hospitals. I mean, the headaches are just growing and seem to be growing in a unique way with Anthem.
So the appeals process and the administrative cost for those claims denied lies with the providers and not with the, okay, I see lots of heads nodding. So that does lie with the providers and not with the patient or customer.
Yeah, you saw a facet of that. When these claims don't get denied, and there is ultimately a patient responsibility, patients get frustrated when they don't see their share of the bill for 6 months or 9 months. You've seen legislation on that. Hey, why did I get this bill so late? Well, there's 350 million of them caught up in that world for a long time. And so it does have patient headaches about timeliness. So you've seen that legislation, yes.
Thank you.
Mr. Austin, my question is about the market conduct exam, and wondering if the Maine Hospital Association will be providing data to the Bureau to try and assist with their market conduct exam. I guess it's a request if you are not already involved in that process, because it didn't sound like there was a formal way for that to occur, but it seems like something that should occur.
We did provide them a while ago the results of the survey, and we'll have to huddle about how and if and in what ways it's appropriate for us to participate in that. So thank you. Yes.
Great. Yeah, my concern is that the numbers, for example, that Ms. Trundy reported with regards to timely payment just don't seem to match what we're hearing from providers. And I feel like there has to be kind of not just Anthem self-report on that issue of timely payment because I think the providers may have a different view of it. I want to make sure that the Bureau has both sides. So thank you. Okay. See no further hands. I'm going to move Mr. Austin back into attendees. And the next person on my list is Molly Smith, followed by Jay Mullen and then Karen Foster. And I'll just be moving people over one at a time. All right, Molly Smith, please welcome to the Health Coverage Insurance and Financial Services Committee. Go ahead.
Great, thank you so much. And Senator Sanborn, let me start by first wishing you a speedy recovery, but to you and Representative Tepler and the distinguished members of the Joint Standing Committee on Health Coverage, Insurance and Financial Services, good afternoon and thank you for having me. So I am Molly Smith. I'm Group Vice President for Public Policy at the American Hospital Association. We are the national association that represents the full range of US hospitals, including many of the physicians, nurses, and other professionals who work within those organizations. I appreciate the opportunity to speak with you today and share our concerns regarding certain Anthem business practices that challenge hospitals' ability to care for their patients. We hear weekly about issues with Anthem from hospitals across the nation, from California, Virginia, New Hampshire, Georgia, and Indiana, among others. So this is not a problem that is unique to Maine Health, and it's not even a problem that's unique in the state of Maine. Some of the challenges that we hear about most frequently have already been raised here today, but there are some that haven't. So I'm just going to run through a few of those. The first one has gotten a fair amount of airtime, and that has to do with these mid-year changes in Anthem enrollees coverage, limiting where patients can get care after their coverage has already started for the year. There are also attempts by Anthem to steer patients away from their trusted providers to receive certain physician-administered drugs like chemotherapy infusions. We see a lot of full or partial denials of emergency services, which we believe violates federal law. There are delays in patient care resulting from excessive prior authorization requirements, multiple requests for medical records, even after hospitals have sent those records with signature confirmation and therefore know that Anthem has received them. Failure to pay claims in a timely manner, also something that we've touched on a fair amount today, which have totaled in the hundreds of millions of dollars for certain systems in other states, and inadequate processes to resolve these problems. Given time constraints, I've submitted written documentation on a number of these issues. But it isn't just what our members report to us. In fact, there have been 2 significant judgments against Anthem in just the past few weeks. So one of them has been raised several times, and Representative Arford has flagged the recent action in Georgia by the State Department of Insurance when it fined Anthem $5 million for, I quote, when it uncovered a number of serious issues, including improper claim settlement practices, violations of the Prompt Pay Act, failure to reply to consumer complaints in a timely manner, inaccurate provider directories, and significant delays in loading provider contracts, unquote. Second is in Indiana. According to an Indiana Business Journal article that I also shared with the committee, an arbiter recently found fully in favor of 11 hospitals in Indiana who challenged Anthem's denials of emergency services. But despite this decision, we understand that Anthem continues to apply this inappropriate coverage policy. And I just want to say that these problems aren't just fights over reimbursement. They impact patient access to care and they contribute to clinician burnout. But to be frank, delivering high quality care does require resources. I could go through all the things that hospitals, which are very complex organizations, need to spend money on, whether staff, supplies, or otherwise, but I see my time is up. So I will just say that we are deeply concerned about these business practices and the impact that they have on patient access to care. We've publicly asked Anthem to revise its policies, and we've raised our concerns with federal regulators. We really appreciate your attention to this matter so that Mainers can expect nothing but the highest quality care and coverage. And I'm happy to take any questions you may have of me.
Thank you, Ms. Smith. Are there questions for Molly Smith? All right, I don't see any. Thank you for joining us today. I am going to move you back to the attendee space. And the next person on my list is Jay Mullen. And again, I've got Jay Mullen and then Karen Foster, Gwen Simons, Annie Norman, and Robert Reed coming up next. Good afternoon, Dr. Mullen, you are on mute.
The Zoom will become second nature at some point, I guess. Senator Sanborn, Representative Tepler, members of the committee, thank you for spending a few minutes listening to my point of view. My name is Jay Mullen. I'm an emergency physician from Freeport. I'm a member of the board of directors of the Maine Medical Association, and I'm the chair of the legislative committees of both the Maine Medical Association and the Maine chapter of the American College of Emergency Physicians. Today, though, I'd like to add my perspectives as the CEO of Blue Water Health. Blue Water is a 100% physician-owned medical group which staffs emergency departments with emergency physicians and non-physician providers. We staff Midcoast Hospital, Holton Regional Hospital, and several hospitals throughout New England. Until recently, we've been proud to be an in-network with Anthem at all of our locations, but are seriously questioning that partnership. As a previous panelist noted, something has really changed with Anthem, and there are 3 areas that I'd like to touch on. First, Anthem is simply not paying their bills on time. At this moment, more than 25% of our bills to Anthem are more than 6 months past due. As any small business owner can attest, if customers don't pay their bills in a timely fashion, cash flow becomes a significant challenge. Second, Anthem is denying claims, and it's putting their members, our patients, at medical and financial risk. The carrier is using diagnoses to refuse or reduce payment in violation of federal and state laws meant to protect patients who prudently go to ERs for evaluation of potentially life-threatening symptoms. When, after the thorough ED evaluation, including x-rays, EKGs, lab work, et cetera, it turns out that they have a non-emergent condition, Anthem is denying coverage or reducing payment for that ED visit. Think about a heartburn diagnosis when a patient presents thinking they might be having a heart attack because of chest pain and diaphoresis. Protections like the prudent layperson standard exist because the only thing anyone should have to worry about when they believe they're having an emergency is getting to the closest emergency department. I've attached a copy of a letter that Anthem was sending out to its patients a few years ago, threatening, save the ER for emergencies or you'll be responsible for the cost. Third, Anthem's not been an easy partner to engage in good faith negotiations with. In Blue Cross Blue Shield of North Carolina, for example, they've been sending letters out to physicians demanding as much as a 30% cut in their contracted rates. If the physician fails to comply within 2 weeks, they're kicked out of the network. I've added an example of that to my written testimony as well. And just as an aside, we collect much less than 165% of Medicare from Anthem. And in summary, patients use the ER in good faith. Emergency physicians care for those patients in good faith. And it seems reasonable that we should expect Anthem to act in good faith when they interact with their members and physicians. Right now, it just doesn't appear that they are. With that, I'd be happy to answer any questions.
Thank you, Dr. Mullen. As you know, because you were involved in it, in the 129th legislature, we did adopt the prudent lead person standard into statute. Have you seen any change in emergency denials based on our change in statute to make it clear that the consumer should be able to go to the emergency room if they think they should?
So mostly that legislation covered surprise medical bills when somebody was out of network. For my group, we're in network with every major payer. So we don't actually see that. But interestingly, Blue Cross Blue Shield is actually referencing the No Surprises Act when they tell emergency physicians that they have to take a cut in their contracted rates.
Can you say a little more about that? I don't understand.
Yeah, so in the No Surprises Act, the qualified payment that comes out initially is the median in-network rate. And so what Blue Cross Blue Shield is doing across the country is they're looking for any provider that gets paid above median. And they're basically telling them they have to accept below median or else get thrown out of the network. And it's a mathematical game because then as soon as you cut out the higher end contracts, the median naturally falls even lower.
Okay. I thought we had changed it to make it clear you couldn't deny emergency room coverage if you thought you should go to the hospital. I thought that was a specific bill that we worked on that was different, or maybe there was surprise billing regulation in the same bill, but that there was a provision very much about making sure you were covered if you went to the hospital.
Yeah, no, your memory is correct. We actually passed one of the best prudent layperson standards in the country. But what happens is carriers, and Anthem kind of is the poster child for this, are finding ways to chip around at the edges to try to stay within perhaps the letter of the law, but certainly not the spirit of the law.
Okay. It seems like an issue for market conduct at this point, given that we have a prudent layperson statute that we passed 3 years ago now, I think. So maybe another thing worth writing specifically to the attention of the Bureau to let them know about the violations of that prudent layperson standard, because we were very serious in enacting that statute. It needs to be enforced. I don't see any other hands up. So we appreciate you joining us today. I'm going to move you back to the attendee space. The next person I have on my list is—
Thank you, everyone.
Thank you. The next person I have on my list is Karen Foster. And let me go find, her hand is down. Oh, now she's disappeared. There she is. Okay. All right, Karen Foster, if you're with us, you can activate your video and unmute your microphone, and we'll be glad to hear from you for 3 minutes.
Thank you very much, Senator Sanborn and Representative Tepler and other members of today's committee. This has been a master class in healthcare networks since 10 this morning, and I appreciate the time you're putting into this. My testimony today is in my capacity as the chair of the board of Maine All Care. It's a nonprofit organization founded in 2010 to advocate for universal, high quality, publicly funded healthcare for everyone in Maine. And our supporters have been in front of your committee many times. You've probably heard the arguments for a single payer healthcare system, and they're just as relevant today as they have been for the last 15 years. I think that what I would like to ask you to do, having listened to what is brought us here today, the initial issue being the dispute between two big players, is really more than that. And if I could have a wish, it would be that you would broaden your lens in terms of thinking about what the solutions may be. You've asked that question of some of your panelists, and I haven't heard anyone say, why don't we take a look at the forest instead of focusing on the trees? There is a fundamental issue with healthcare. We would assert that the only way to deal with it is to give you some levers and some authority that you don't have today to deal with it. And that if the state had a unified payment system under a universal healthcare system, it would cut out the need for network negotiations. It would provide for payments similar to what Medicare is able to do in a timely manner, and would actually, and most importantly, benefit the consumers whose voices have really not been heard as much today as I wish they had. One solution we're looking at, and maybe you could help us work with this, is a bill that you passed at the end of the last session. It started out as LD 1045 as a large universal healthcare bill. It was amended to be a very tidy 3-page bill, which created the Maine Healthcare Act. It's will go into effect when the federal government allows states to do a universal healthcare plan and provides a funding mechanism for it. So we're looking at the possibility of relying on waivers under the Affordable Care Act as a way to potentially make that happen. We've got to start somewhere. Patients individually are powerless against the likes of Anthem and Maine Health. We know that. And unless and until the legislature really gets its hands around this and decides to take serious action, I'm afraid we can just expect more of this. So the goal today is not to settle this dispute. It's really to take a look at what we can do to make such disputes as this unnecessary. So thanks very much for your time.
Thank you for being with us, Karen Foster. Are there any questions? All right. Not seeing any. I appreciate your testimony today. I'm going to move you back to the attendee space. The next person on my list is Gwen Simons, followed by Annie Norman, Robert Reed, and Jonathan Fellers. And I'm just letting people know, I'm just announcing the next few people on the list. It's not an exhaustive list yet. because they do have a number of other folks that are going to be testifying. All right, good afternoon. Ms. Simons, please go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and honorable members of the committee. My name is Gwen Simons. I'm the lobbyist for the Maine chapter of the American Physical Therapy Association, and we represent over 2,500 physical therapists and physical therapist assistants in the state of Maine who work for Maine Health, other facilities, and private practices. You have access to my written comments that were submitted after 2 p.m. yesterday. But first, I'd like to echo the complaints of the other providers who have already testified. And then second, I would like to share in Senator Sanborn's questions about how the Bureau can enforce Maine's laws upon complaints from providers, because patients really do not understand these issues, nor do they understand the laws that apply and what laws that Anthem might be violating in order to complain. We believe that the provider complaints should be taken into consideration in the Bureau's market conduct analysis, and we really need to figure out a way for the Bureau to be more responsive to provider complaints, even if it requires a legislative remedy. And I want to use the rest of my time to push back on many of Ms. McDonough's comments from Anthem. First of all, Anthem has not met with Maine PTs. I have personally asked to meet with Anthem repeatedly over the last several years on behalf of private practice PTs in Maine to discuss numerous issues and have been dismissed. We still have PTs in Maine who have not been paid after Anthem system updates kicked them out of the network. I question how the same inept system updates can be causing problems over multiple states since 2015 and not be a system-wide issue. Another nationwide issue that has recently come up is where AIM, which is Anthem's subsidiary that performs their pre-authorization, has suddenly and erroneously started telling PT providers that patients did not need pre-authorization when they actually do. Anthem again stated this was due to a system update gone wrong, and most providers actually continue to see their patients in reliance of this erroneous information. We're just waiting to see if those claims get denied, so stay posted. Anthem's extraordinarily burdensome pre-authorization requirements have doubled providers' administrative costs and are designed to arbitrarily deny medically necessary pre-authorization care at the pre-authorization level. When providers and patients appeal, Anthem does not provide a full and fair review. They rubber stamp their denial, knowing that most patients won't proceed to ask for an independent external review, and providers have no right to an external review under their provider contract. Anthem's contracts of adhesion require providers to engage in costly mandatory arbitration to settle any dispute. Anthem's below Medicare rate reimbursement to private practices and many, many other problems that we don't have time to discuss today are making many PTs in Maine consider going out of network with Anthem. New practices that are starting up in Maine are choosing to stay out from the beginning. And that is going to create a potential access crisis for PT services in the future. You heard Denise McDonough's testimony today.
Can you wrap it up for me, Ms. Simons? I'm sorry, I didn't give you enough warning there, so I gave you a few extra minutes or seconds, but if you could wrap it up, that'd be great.
Just a couple more sentences. You heard Denise McDonough's testimony today that Anthem is working hard to restore the trust of providers, and we want to hold her to that and request publicly to meet with Anthem and in good faith to discuss these and numerous other problems. And we thank you today for the opportunity to give the PT's perspective.
Thanks, Ms. Simons. Are there questions? All right, I don't see any. Thank you for joining us today. I'm going to move you back to the attendee space. I did hear from Dr. Norman that she won't be able to join us. So we'll move on to Robert Reed, followed by Jonathan Fellers and Jennifer Kent. Good afternoon, Robert Reed. You can activate your video if you're able to. You can go ahead.
Thank you. Good afternoon, Senator Sanborn, Representative Templer, members of the committee and the legislative staff. Thank you for allowing me to testify on the issue. My name is Robert Reed. I'm the Executive Director of the Maine Chiropractic Association. I have 10 years experience working in claims and provider services for the former Blue Cross. I can tell you Anthem is not Blue Cross. It's not the same company. Since then, 25 years working in healthcare finance and reimbursement. 12 months ago, conditions with Anthem were so poor that we saw chiropractors begin to leave their network. Many of our doctors were reporting claims to Anthem in excess of $50,000 at any given time, and a few of the larger practices had outstanding debts of $250,000. For solo or small group practices, that represents a significant amount of revenue towards payroll and operational expenses at a time when our providers were putting more money and seeing less patients because of COVID. Calls and emails to Anthem were met with, "It's how you bill or you use the wrong codes." We thought we were alone, and perhaps it was our coding that was only for this insurer, but we've come to realize differently. Last fall, we began seeing reports of mental health providers denied as no longer being in Anthem's network. The failures were communicated to them as it was a software glitch from a system we tried to implement. At no time did Anthem seem to really take responsibility or work with the providers directly to address the issue. I actually worked with several mental health professionals due to my past involvement with some of those to help them get online. Maine Health is simply the latest in a long line of people. Soon after we saw the mental health, we reached out to other medical associations and found this was not a simple issue, but rather a large issue of unpaid claims. That led to a formal complaint and meeting with the Bureau of Insurance by chiropractic, physical therapy, osteopathics, podiatry, optometry, mental health, and other providers requesting action. Results of that meeting, we were informed that a market conduct examination of Anthem would begin, which we hoped would lead to a positive outcome for healthcare providers and consumers through the state. On a national level, CMS each year offers guidance on claims payments to the insurers called the CCI edits, or the Correct Coding Initiatives. They're provided to Medicare, Medicaid, and commercial carriers take those, and it allows them to process claims consistently and accurately. What Anthem has done is disregarded, for the most part, the CCI edits, and instead gone to something they euphemistically call algorithmic downcoding. Algorithmic downcoding has nothing to do with algorithms. There is no algorithm. I can tell you that I could bill the same service 5 times to the same patient and get 3 payments and 2 denials with no other changes within a week. This is not correct. Yesterday, we were made aware of a new issue. Anthem is now requiring more from their providers. I can get to that later. Just quickly, Anthem mentioned they're a separate organization in each state. Yet when our providers try to speak with them about the contract, we're told that Anthem looks at what the other states pay, and therefore we think we're paid correctly. Paid correctly means we're now making less than we were paid in 2008, and we're less than 100% of Medicare at this time. Thank you.
Thank you, Mr. Reed. What was the other issue that you stopped telling us about when I showed you that you were almost out of time?
Yeah. Patients suddenly are getting now requests for coordination of benefits, questionnaires, and that's normal in the person. If you think they have other insurance, you might send out a COB questionnaire, but Anthem's just taken it to a new limit. We're seeing a substantial volume, and then if the patient doesn't answer quickly enough, Anthem is not only denying claims, but taking back prior payments. And they're saying it's based on information they have on file, but that information isn't being shared with us. And the other piece of that is, I want to get to the claims being paid timely. Claims paid timely is the most overused, incorrect statement anybody could make. A claim paid within 14 days could mean it was actually denied, but it was paid, it was processed. It could also mean it was a partial payment, which is what we see with chiropractic, PT, and a couple others, where some services are paid, but we've still got to go back. A better question to ask might be, how many of those claims paid correctly later needed additional adjudication to completely resolve. I thank you. I don't mean to take up your time.
Yeah, no, that's a helpful nuance there, and part of the reason I think why Ms. Trundy's statistics don't really match provider experience. And I think that's some important piece for the Bureau to keep in mind. Mr. Reed, I think I'll say the same to you as I did to our hospital testifiers, that, you know, I think the Bureau needs as much information as you're able to give them. And, you know, staying on top of that market conduct examination will be helpful to all Mainers, I think.
Unfortunately, the Bureau will not, for the most part, take testimony from providers. And as they stated, that's a statutory thing that we would like to see changed in the future, that we now can advocate on behalf of a patient, but we have very limited means to speak with the Bureau. This literally took us going to Channel 6 News and getting some publicity before we could really open those doors.
Yeah, understood. Okay. Thank you for being here with us today. The next person I have on my list is Jonathan Fellers, followed by Jennifer Kent and Philip Caper, and then Dan Morin will round out our testimony, and then I'll check if there's anyone that I missed. So I'm going to bring over, or someone already did. Nope, there he is, Jonathan Fellers at this moment. Great. Let's proceed.
Great. Thank you. Senator Sanborn, Representative Tepler, and the distinguished members of the committee. My name is Jonathan Fellers, and I am a psychiatrist, and I established a private practice about 3 years ago. In early 2021, I began noticing a discrepancy between what I billed and what insurance paid with some patients. A pattern quickly emerged. Starting in January 2021, Anthem unilaterally downcoded claims that prior to 2021, they would have honored. For example, for some patients, I billed for a 30-minute appointment, but Anthem would automatically change my bill to reflect a 15-minute appointment and pay me for that instead. Investigating the explanation of benefits for these claims revealed that a Cotiviti edit prompted the downcoding. Further inquiry yielded they were purposely processed at a lower level of office visit code per the Cotiviti edit. The original office visit E&M codes that they billed are for a longer session. However, based on the edit and the condition diagnosis billed on the claim, a lower level, shorter session of visit is more applicable. This is not a system issue, and you will need to send medical records to support the need and usage of a higher level of service. Our office spent hundreds of hours mailing physical copies of patient records to Anthem's headquarters in an effort to appeal these claims. My office's frustration with Anthem's apparent disregard for our agreed upon contract and fee schedule found no audience with our multiple calls to Anthem. Telephone agents recommended speaking with Anthem Provider Relations. However, no one had contact information for this department. Others referred us to reach Anthem through the Availity portal, but these repeated efforts were again unanswered. The added administrative burden to justify our work made continuing to see patients with Anthem untenable. I made the difficult business decision to leave the Anthem network in April 2021. I am concerned that Anthem is unfairly using their oversized market position to push the limits of providers' good nature. As a solo practitioner in an Anthem dominant state, I have felt the striking power differential in working with such a heavyweight. Though I am no longer in network with Anthem, I continue to see patients with Anthem insurance. We continue to experience challenges with claim processing. Anthem asserts that they process 92% of claims within 14 days and 98% of claims within 30 days. My office manager estimates that though the claims are processed quickly, over 90% of these claims are processed incorrectly and the claim must be resubmitted. Correct processing is elusive. Same patient, same code, same everything will pay differently in back-to-back months. For some patients, we submitted claims, but they never received an explanation of benefits and we were unable to look up the claims online. By calling, we discovered that Anthem had paid the member, but they never informed us of any of these things. Details have now emerged that this is a widespread practice. Though this grassroots advocacy is encouraging, I wish to point out that formal oversight of health insurance and protections are provided for consumers, but not for healthcare providers. Thank you.
Yeah, thank you very much for sharing that with us. Are there any questions for Dr. Fellers? All right, I don't see any, so I'm going to move you back into the attendee space. Thanks for joining us this afternoon. Next on my list, I have Jennifer Kent, Philip Caper, and then Dan Morin, and then I see Sandra Picard with her hand up as well, so I'll add to the list. Good afternoon. Please proceed.
Good afternoon, Senator Sanborn, Representative Tepler, and distinguished members of the committee. My name is Jennifer Kent, and I am the Executive Director for the Maine Education Association Benefits Trust. We're a not-for-profit employee welfare benefit plan dedicated to the health of Maine public school employees and their families. Our plan offers health insurance to approximately 68,000 active and retired educators, support staff, and their dependents in the K through 12 schools throughout Maine. Our active and retiree medical and prescription benefits are insured by Anthem. The trust has worked hard to provide our members with the best health and wellness plans at affordable rates. In March, our Board of Trustees renewed with Anthem for the upcoming plan year of July 1st, 2022 through June 30th, 2023, and rates were distributed to all of our participating schools. We are very concerned about the impacts of an unexpected mid-contract termination of Maine Medical Center from the Anthem provider network, particularly as it will occur in the middle of our insured contract year. Schools and towns have developed budgets and tax rates based on our negotiations with Anthem, which assume Maine Medical Center is paid as an in-network provider at the in-network rates, which were mutually negotiated by both parties as part of their 3-year contract. The trust has worked hard over the years to keep increases in medical premiums as low as possible for our members, the school districts, and taxpayers, while also investing in tools and resources to help keep our members healthy and productive. In addition to cost considerations, Maine Medical Center going out of network mid-contract is an unprecedented disruption to our members, adding unnecessary stress after everything that they have gone through during this pandemic. We certainly respect the ability of parties in any negotiations to disagree. We do know, however, that this is no ordinary contract negotiation. The issues are far more complicated than what has been captured in the news reports. The resolution of this dispute will have far-reaching consequences to the delivery of affordable health care in Maine for years to come. A solution requires compromise by both parties and an awareness and an appreciation of their respective perspectives and of the mutual responsibility to the community that they both serve. We do not believe that our carrier should automatically agree to any increase proposed by a provider, especially mid-contract. We expect our insurance company to work to mitigate costs and trends to provide our members access to the best care at the best possible price. We also note that it is important for providers to be paid correctly and promptly to support the delivery of ongoing quality care. We continue to encourage compromise and flexibility by both parties to reach a resolution that is first and foremost in the best interest of the patients and members. Contingency planning for the largest hospital in the state being out of network for the largest carrier in the state is complicated and takes time. And as you heard from the state, trusts like ours and other stakeholders will need to develop prudent and appropriate alternatives for our members if this dispute is not satisfactorily resolved. So thank you for your time.
Thank you, Ms. Kent. Very helpful perspective. Are there questions for Ms. Kent? All right, I think we share your concern that things get resolved between now and January 1st, for sure. I'm going to send you back to the attendee space, and
thank you.
Thanks for being here. I'm going to bring over Phil Caper next.
How's that?
Great. Good afternoon. Go
Great.
ahead.
Thank you very much, Senator Sanborn and Representative Templer and the other members of the committee. I'm Phil Caper, Dr. Phil Caper. I am a retired internist, and I've been an advocate for universal health care for over 50 years. When I started as a chief health advisor to the chairman of the United States Senate Subcommittee on Health, and I've been at it ever since. What we have all witnessed today is the dynamics of a failed market at work. Our flawed and ill-advised market-based, for-profit and competition-driven system codified by the ACA is behaving not as it was intended to do, but as it was designed to do. This is not a failure of Anthem or Maine Health. Everybody is just doing their job as they see it. We're watching market failure at work and conflict created by a misalignment of incentives and of missions among the players. Competitive markets do not, have not, and will not ever work in healthcare for reasons that I detail in my submitted written testimony. So who's at fault for this mess? When you put the fox in charge of the chicken coop and the chickens begin to disappear, you don't blame the fox for being a fox. You have to ask who put the fox in charge. This is a failure of public policy. No other wealthy country in the world has relied on a market-based competitive system to control healthcare costs and protect the quality of care and to assure access to medical care. I hope today's hearing has demonstrated some of the reasons why that is the case, and it has helped you to understand why the problems this hearing was intended to address are crying out for systematic and transformational changes. Tinkering with the ACA will never produce the kind of changes that are needed. They'll just kick the can down the road, and we'll be here next year, the year after that, and in a decade, talking about the same problems. This committee and the legislature has to think outside the box. That box is the belief that our for-profit, competitive, and market-based system of healthcare is the right policy. What is needed is a transformational change. We need to return to a system based upon patient welfare, not money, sound health planning, and cooperation among nonprofit sources of financing, healthcare delivery entities, including doctors and patients. Dirigo, we can do it. So I would urge you to think outside the box. This problem is entirely political. It is not a shortage of resources. It is not technical. We know how to do it. Maine All Care, which I helped found, has commissioned the path forward through activation of PL 391. If that could be done, the only remaining question the beneficiaries of this change, all of the people in Maine, would ask is why did it take so long?
Thank you, Dr. Caper. Are there any questions?
Heather, I'm wondering if, are you aware that the same situation played out in Massachusetts about 10 years ago when the Mass General, when the Mass General tried to get out of the Tufts Health Network? And it was a very interesting case study. Is anybody interested in knowing how it turned out in Massachusetts?
Sure. Can you give us the bullet point version?
I can. The Mass General mounted a very aggressive campaign of scaring patients to try to pressure Tufts into raising their reimbursement rates to match the Mass General's very high prices. And ultimately, Tufts caved in, raised their rates of reimbursement and also their premiums to their customers at the same time. But there was no winners in this fight because the Mass General, by conducting such an aggressive scare campaign, using patients as pawns in a fight between two big corporations, did not go down very well with the public. And the Mass General's reputation suffered badly, even though it's arguably the most prestigious hospital in the world. So beware.
Thank you, Dr. Keeper. Thanks for your cautionary tale out of history. Those are all very helpful. All right, I'm not seeing any hands up, so I'm going to move it back to the attendee space. And we're going to bring over Mr. Moran. I think he's on his way. The wormhole is a bit slow today. There he is. There he is. Great. Good afternoon.
Wow, that was a long wormhole. Holy cow. Thank you, Madam Chair, members of the committee. My name is Dan Moran, Director of Communications and Government Affairs for the Maine Medical Association, the state's largest professional physician organization, representing more than 4,300 current and future physicians across all specialties, organizations, and practice settings. Thank you for providing a forum for stakeholder feedback. While we appreciate the widespread attention resulting from Maine Health's announcement, the MMA has been receiving independent member complaints since early 2021. At the end of our testimony, you'll see some media links to that. Independent physician practices are arguably impacted more by an extraordinarily unequal bargaining position with carriers. The pandemic certainly hasn't helped. One solo practitioner, this is included in Dr. Barkin's testimony, which is attached to ours. He was unable to make it today due to a family issue, but one solo practitioner turned to a home equity line of credit to keep their practice alive. Smaller community-based physician practices do not have access to large reserve funds when things get tough like large organizations do. During Q&A this morning, the carrier asked for understanding, spoke of recent systemic operational challenges and an intent to be better. We found that quite humorous. If an independent physician makes an unintended claim submission error or an innocent omission, they don't get paid, period, and are forced by that same carrier to navigate complex bureaucratic and time-consuming appeals regularly lasting more than 6 months. There's no such empathy. Those efforts can eventually cost more than the reimbursement that's rightfully owed. That's the figurative and literal cost of every claim can be disputed, which was stated this morning. Countless reimbursement claims submitted by independent physician practices were arbitrarily downcoded. You heard of that earlier. And payments reduced and withheld totally based on a diagnosis code entirely determined by a computer algorithm. No review of medical necessity, medical facts, or medical records. Quite frankly, it was a system that saved the carrier money by reflexively denying medical care determined necessary by a physician. We actually haven't received any word that the claims process has become any easier since Anthem discontinued the cotivity at its adjudication process in September 2021. Dr. Barkin's testimony and what we've heard at MMA, many psychiatric physician practices are still experiencing underpayment for behavioral health therapy codes. They've told us their practices are existentially threatened by a failure to be paid what they're rightfully owed in a timely manner at a time when the shortage of psychiatrists in Maine is near crisis levels. And I have a link to a story that describes that. We're at a critical moment where the need for mental health care is greater than ever before. Most concerning, which has also been touched on today, individual physicians and practice managers are oftentimes unable to speak directly with peer reviewers or medical directors supervising the claims. And I'll finish by referencing a couple of attachments to our testimony. They give a good visual of what Dr. Fellers was mentioning. You'll see one of the explanation of benefits that was sent to one provider that just pretty much says, we're not paying that, and reduces a code. And then the second one is a denial letter that really doesn't give any information. It pretty much says, yeah, we entered that correctly. We've determined that we're going to pay you less. So take a look at that. And that's what physician practices have to look at and work off of. So thank you for considering our comments. We'll be glad to provide any more information in the future if you choose to request it.
Thank you, Mr. Moran. Are there questions for Mr. Moran? All right, I don't see any. Oh, yes, I do. Representative Arford, go ahead.
Very quickly, we've had not much we've had really no conversation about the behavior of other carriers, major carriers in the state of Maine, but there has been alluding to the fact that Anthem is very much an outlier in the way in which that they are responding to the claims that they receive. Would you agree with that? Do you have any further comment to make on that?
What I can tell you is the feedback that I receive and CEO Andy McLean receives about concerns with Anthem's claims processing far exceeds other carriers. It's not even close.
Thank you.
Yeah, I suppose we could have asked everyone who came to testify today really about that question. And I've thought of it a number of times and haven't asked it of everyone, but perhaps should have. And if anyone wants to provide us written commentary on that, you're certainly welcome to do so. All right, I don't see any other questions for Mr. Moore. So I'm going to move you back to the attendee space and thank you for being here. And I am going to bring over Sandra Picard. And by written comments, I meant by email to Ms. McCarthy Reed. We really still can't look at the chat for any written comments. I'm sorry if that was unclear. All right, welcome.
Sorry, I lowered my hand before the break, and so evidently I didn't know that I needed to put it back up. So I'm sorry to keep you, especially where you're feeling so poorly, Madam Sanborn, but I really appreciate the opportunity to talk with you. I've been a nurse practitioner and PCP for over 40 years. And Anthem was my favorite payer. They paid the best right up until about a decade ago. But everything changed about then because it was no longer a collaborative or for what the patient needed and wanted. It was more all about the numbers, the money, and the paperwork. And I don't think Anthem is unique. I think it's only because Anthem is the big boy in town. Because when Aetna, for the brief period of time, was the state insurer, then I thought, wow, this is going to be great because the CEO was promoting alternative care and what actually worked for patients. Unfortunately, that didn't carry over to what they would cover for us as providers and as patients, and especially being in one of the top states for Lyme disease, patients are not getting coverage for what they need. And many of us are having to go out of state in order to get the coverage that we need. And I actually have lost over 1.5 million because of lack of reimbursement from all payers, and Anthem in particular. It was 3 years that I was waiting for a response for why I hadn't been able to get paid, and a number of issues were also involved, including the poor internet and phone service, which got even worse when everyone was working from home and unable to get online. Just recently, a provider relations agent from Anthem called me and said that she had just found my letter in the bottom of her drawer. And it's unbelievable that patients do not get the care that they deserve, and that there's not equal access to all for testing and treatment for what works, and only the wealthy are able to afford to pay out of pocket and have to go to other states in order to get the care that they need. I hope that this will change and that you can make it happen with not only, like I said, it's not only with Anthem and with Maine Healthcare. I think it's all over. And it's denial of what exists and of what patients deserve for their own care. Thank you.
Thank you, Ms. Picard. Are there any questions? All right, seeing none, I'm going to move you back into the attendee space. Thank you for being here with us this afternoon. I do see Mr. Reed's hand up again, but we're not going to take a second round of comments. We could be here all night that way, so we're not going to do that. But anyone in the meeting is welcome to submit written follow-up to the committee via Ms. McCarthy Reed, and you can find contact information to submit written comments on the committee's webpage, where the listing for this meeting is located as well. And she will continue to forward any written materials that are sent to the whole committee as they come in periodically. So with that, I think we have reached the end of the public comment period. I'll just check again. Ms. McCarthy Reed let me know that there's no one in the room wishing to testify in person, and she's given me the thumbs up on that. So with that, we have taken all of the comments today, and it's a lot to digest. I took about 10 pages of notes, and I need to do some of that digesting myself. But wanted to just briefly open it up to the rest of the committee if there's any final comments or announcements or anything like that before we adjourn today. All right, I don't see anything. So Representative Tepler is going to raise her hand after I say I don't see anything. Go ahead.
Thanks, Madam Chair. Sometimes it takes a moment for me to cogitate on the issue. I think I'd like to think about some more communication with the Bureau of Insurance, just a more clear sense of when they think the market conduct survey would be completed. And perhaps that's just something we can ask them for in writing, but it was very unclear to me when they thought that might happen or even when it began. And I realize there are a lot of confidentiality issues with it, but knowing that this disconnect in terms of network will happen in January, I really would like to urge them to proceed with all alacrity in the hope that the market conduct exam will affect the final outcome here. And that's just something I think this committee can do or think about.
Yeah, thank you, Representative Tepler. And I see that Mr. Yardley and Ms. Rawlings-Secunda are still in the meeting, so they heard you say that. And if they can respond, I'm sure that they will. All right, I don't see any other hands up. So I don't have a specific set of next steps for the committee or any sort of info about what the outcome of this meeting might be, but I think we've taken in a lot of really important comments about the situation, and I think helped to get a little bit deeper than the press articles have been able to do, and teased out some of the nuance here. So I appreciate everyone spending the day with us to accomplish that, and seeing no further hands up, I think we should stand adjourned, and we'll see everybody on Monday the 9th.
Feel better, Heather.
Get some rest.